Okay, bleeding and shock, all right? So, as it says over here, all bleeding stops eventually. Your job as EMTs is to prevent it from stopping eventually and get it to stop as soon as possible, okay? We know already from CPR that we have, 4 to 6 minutes before brain cells and other important organs start to die, okay, with lack of oxygen. The purpose of blood is to, one of the purposes is to transport gases around the body. If we just let somebody bleed out, will it stop?
It's the same
At some point it will stop, right? It will.
Someone's bleeding for 4 to 6 minutes.
Yeah. So that's really all you have, because that's all it's going to take. It's not going to take long, and they will bleed out completely, and then we'll get into tonight the problems and everything that occurs with this, all right? So here we go. We start off, as always, with a very brief review of the anatomy that we are concerned with. We're concerned with the heart. We spent time dealing with the anatomy of the heart. This is something that each and every one of you must know, okay? Everybody needs to know this, and let's just run through it really quickly. There are two separate systems, okay? There is the right side of the heart and the left side of the heart. If you remember, we spoke about this. The right side is doing what? It's getting all the heart, or it's getting all the deoxygenated blood back from the superior inferior vena cava, and that is all the deoxygenated blood that has been used by the body, and it gets returned to the right side of the heart. Remember this, the right atrium goes into the right ventricle. From there, where does it go? Right, from the right atrium through the right ventricle, then goes into the pulmonary veins. Now, what's special about the pulmonary veins? Pulmonary arteries. Okay, what's special about the pulmonary arteries?
Does it carry both?
It carries deoxygenated blood. Pulmonary arteries, right? The only one that we've told you about, that we've told you so far in the body. Pulmonary artery. So the pulmonary artery leaves the right ventricle and goes to where?
To the lungs.
To the lungs, right? How far is the distance from the heart, right side of the heart, to the lungs?
Very close.
Very close. It's right next door. Therefore, this is called a low pressure system, right? That is the whole deal. It's not got to get very far, so the right side of the heart does not have high pressure that we talk about when we talk about systolic and diastolic, and the blood pressures that we take have nothing to do with the right side of the heart.
But there needs to be pressure in order to get that.
There does need to be pressure, and if you go and learn a little more medicine than EMT, we will talk about pressures in all the different parts of the heart and how we can measure them. But this cannot be done in a non-invasive way in the back of an ambulance. So of course there's always a pressure gradient between two places in the heart. But it's not something you have to worry about. You have to understand that it's a low pressure system. Okay, the right side of the heart only has to squeeze enough to get the blood from the right ventricle to the lungs, and that's through the pulmonary arteries. Remember the arteries that break the rule, if you like, that carry deoxygenated blood. Everybody got that? This is review. Left side of the heart. This is a high pressure system. Why is it a high pressure system?
It needs to get it around the whole body.
No, it's got to get much further. It's got to pump to the entire body. Okay, from the heart, it's got to go all the way up and all the way down. It's got a long way to go. This carries oxygenated blood. We know it comes back from the lungs through the pulmonary veins into the left atrium, down into the left ventricle, and then from the left ventricle up into the aorta, which we spoke about. We know the aorta is the what? The largest artery in the body, and that sends the blood to all the arteries around the body. So this is just review of the heart and the circulation.
Didn't they say that the veins are the ones that carry the deoxygenated blood?
Yeah.
So
Veins do. This is oxygenated blood.
Right. So why is it called pulmonary veins? Isn't it pulmonary?
Right. This is the only vein
Right.
that I taught you about so far that carries deoxygenated blood. You've got to know these. You will be tested on this. You've got to know
Very
which
oxygenated.
oxygenated. These are the two
So
exceptions.
the pulmonary artery.
Pulmonary artery leaves the right ventricle and goes to the lungs carrying deoxygenated blood. The pulmonary vein brings oxygenated blood from the lungs back to the left atrium. Now, why they called arteries and veins? Why don't we just switch the name?
Goes away from the heart to the heart.
Right, because the direction of the blood flow is how the vessel gets its name.
Because it's called
That is the most important thing, the direction of the flow. Meaning that rule is never broken. So arteries always away. Remember we spoke about that, the AAA. Arteries always away from the heart. When the blood leaves the heart, the right ventricle, it's going away from the heart. It's going to the lungs. Doesn't matter that it's got the wrong type of blood inside it. The main thing, the way we give a name to a vessel, is based on the direction of the blood flow. Remember that. So this blood flow is leaving the heart, going to the lungs, therefore it is it's an artery. On the other hand, veins will always bring
blood to the heart.
to the heart. Again, this blood was now in the lungs, got oxygenated. Now we need to bring it
To the heart.
back to the left side of the heart. Now we're going to the heart. It becomes the name of a vein, even though it's carrying oxygenated blood. This is stuff they will test you on.
And it gets oxygenated in the lungs?
In the lungs, yeah. We'll talk about that. We'll talk about that a little bit later in a respiratory, but we did touch on it. We spoke about the alveoli, the pulmonary capillaries. Remember, we spoke about all this. This is just review. All right? One piece of anatomy that we maybe didn't speak of is the septum. Okay, that is a dividing piece in the middle of the heart, very similar to in the middle of the nose. Okay, it's the same thing. You have one organ with a dividing piece down the middle, that is known as a septum. Okay, it's just a picture, I won't worry about it, we spoke about all this stuff. Okay, great picture, if you can see it here or in your notes, showing some of the differences between veins, arteries, and capillaries, okay? So, here we have an artery. Artery, I told you in classic medical literature, is always in red color, always depicted in red. Okay, and you see that it has numerous layers. Okay, this is a muscular layer. Okay, the blood is all the way in here. All right, and because this is connected to the left ventricle, blood is always moving easily through the arteries. It's directly connected to the pump, right? Remember, the heart is the pump. And that's why when you palpate at one of the sites that we've discussed, you will feel the pulse. All right? Because you're feeling an artery that is directly connected to the pump. Veins, which are typically depicted in the color blue, right? We've spoken about this. They have something inside called one-way valves. See that? See the valve? Mm-hmm. What's the reason for the valve? Well, they're not connected to the pump. They're bringing the blood back to the heart, back to the superior inferior vena cava. So, if there were no valves, the blood may back up easily, all right? And very often, when I put in an IV, you hit a valve, and there's no way to really know where the valves are going to be.
How
They're there
often are
randomly.
they?
They're all over the place, randomly.
What happens if you hit it?
I have two choices. I can either back out and try somewhere else, or if it's a really critical patient, I just bust right through it. Yeah, it's painful for them. Yeah.
There's no long,
Again, these are the choices that I have to make.
there's no long-term damage.
No, no.
It's really painful?
Yeah. Yeah, it's really painful. So they tell me. And the last of the three vessels that I want to talk about are the capillaries, all right? Again, this is review. We've spoken about these before, okay? The capillaries are 1 cell thick, okay? Very, very thin. Look at the difference between a vein, an artery, and a capillary, right? They're very thin. What does that allow for? That allows for
That changes
diffusion, right? Diffusion means that the gases can walk through the walls or the semi-permeable membranes, if you want to say it in real medicine. But basically the gases can walk through these walls and exchange. Okay, and that's where the gas exchange occurs. Okay, gas cannot get out of this, all right? These have a muscular layer, okay? So gas can't move in and out, okay? However, they can move in and out of the capillaries, all right? That's where we're getting the blood to go. Remember, the capillaries join veins and arteries, okay? So it'll be one side red and one side blue. One side oxygenated, one side deoxygenated. Okay, quick recap. Everything here you should know, okay? I don't think we need to go through this. Right, we just did. Arteries usually carry oxygenated blood, always go away. Veins usually carry deoxygenated blood, always go too. Okay, capillaries allow for exchange of gases. Heart, 2 atrial, 2 ventricles, and is the pump of the body. All right, so hopefully this is clear. I think I've spoken about this before. Just again, a review of the 4 components of blood that you as EMTs must know. You must know them, their names, and their functions. Very simple level, just 4 things. RBCs, right? Red blood cells. Here you can see the little donut shape. That's how they're supposed to look. Anybody ever heard of sickle cell anemia? It's a disease. Baruch Hashem, not by Yidden, but we find it in the African American community. A lot, and it's called sickle cell anemia. Their red blood cells do not look like these little perfect round donuts. They have this sickle, pointy piece, and they get stuck to each other and cause clots and cause all sorts of medical problems, all right? So, but that's how a healthy blood cell should look, red blood cell. And they carry gases, remember, right? All you need to know about red blood cells for now, they carry gases. What are the 2 gases that we talk about predominantly? Oxygen and carbon dioxide. Yes, in the hemoglobin, it's all connected to red blood cells, right? White blood cells, okay, we told you they fight infection. That's it. That's all you need to know. Plasma is about 50% of blood, and that is the fluid that makes the other 3 things, which are liquid, which are solids, into a liquid and make blood look the way it does. Yes?
What's the danger in a low red blood cell count?
Oh, so there are many dangers and things that, you know, when we take blood and we check for how much of each thing. All right, so anemia would be one thing that really quickly you would see. Remember, if there's think about it on a simple level, without even understanding anything. If the job of the red blood cells is to carry gases, and now we have a low level of red blood cells, what are we unable to do properly? Carry gases, right? We know the importance, even at this early stage in the course, we know the importance of getting oxygen to each and every cell in the body. So, just on a simple level, without going into any medicine whatsoever, if we have low red blood cells, we're going to have a problem. Let's keep it that simple for now. All right? Platelets are for clotting. That's all you need to know. That's their function. We're not going into the details and the factors and all that good stuff is not for now. Just simple. So again, you have 4 items and 4 responsibilities. Know them. Red blood cells carry gases. White blood cells fight infection. Platelets, clotting, and plasma is the liquid, the fluid, whatever you want to call it, that holds it all
Do
together.
you have a low plasma count?
Sure.
And is that called
Sure.
does that cause clotting? Blood
No, low
clotting?
platelets would be a problem.
No, I mean blood I have blood clotting, blood clots I'm saying, in the body. Does
That
that
may
cause
be elevated. Yeah, there could be problems.
Low plasma.
Low plasma is usually somebody that's bleeding out. They lose everything. So we'll talk about it. Okay, priority demand for oxygen. I was going to remove this slide altogether. I left it in. Basically, the major organs are going to get or try to get their oxygen. And to the extent they're going to take it away from other organs. Okay, let's just leave it at that. We'll explain more a little bit later on. But understand that the heart, the brain, the lungs, even the kidneys, they need their oxygen. They are going to take away from other places if they can, and we'll talk about that as we get on with this
Do
tonight.
they fight within each other?
It's not really a fight, it's more of a pecking order. I'll talk about it. Hemorrhage, all right? We use the word hemorrhage. Remember, any word that begins with hema, hemo, all these words in medicine all have to do with blood. Okay, that is the prefix to any word that has to do with blood. You'll see it a lot. Okay, so hemorrhage is bleeding. That's the word we use for major bleeding. Basically, if you lose about 1/5 to 1/4 of your blood supply, you're gonna be in big problems, okay? All right, how much blood do we have? 6 liters. Just remember, 6 liters. I know it says here 5 to 6. There's a test question on it. Even the state asks this. Okay, the average adult has 6 liters of blood. Okay, you don't need to. They used to teach it, and we used to teach pints and quarts and all. Just liters. Okay, 6 liters. All right.
According to medicine, what's the least amount of blood a person can have to survive?
Again, it has to do with the height. It has to do with your height, not weight. So the higher you are, the more you're gonna have.
Especially reviews.
Okay.
I don't know if it's really.
I don't know if that's possible. And we don't know all the, how they came up with that cheshbon. We're definitely gonna need about. Listen, if you have 6 liters and you lose 1/4, right?
1.5. It's 1.5.
1.5.
But you donate. When you donate blood, you're giving.
Oh, very good question. I will address that in a slide.
It's a slower loss.
I will address that in a slide.
You're not giving a
Yes.
liter of blood.
Yes, you do.
You are giving about a
Exactly
liter
how
of
much
Yeah.
it is.
But you're giving it slower.
That's why. Anyway, let's just move on. I will address that question. It's a good question. Conditions, serious bleeding. All right, so let's talk about this. Mechanism of injury. I don't know if I've ever mentioned this. Okay? This is something you're going to hear a lot in this course. Mechanism of injury, we shorten it to MOI. Okay, so you can write that. You need to know that abbreviation. MOI stands for mechanism of injury. We're going to use it a lot as we get more into trauma and as we get more into assessment of our patients. We're going to use this term. MOI means mechanism of injury. How did it happen? That's all. It doesn't have to be medical. This can be in plain, fell off the roof. Okay, plain old English, whatever, it's fine.
Cause and effect, basically.
Not even the effect, just the cause.
Right.
Just the mechanism of injury. How did this person get hurt? Okay, and we use that when we come to any scene we're going to assess quickly in our head, what's the MOI, right? Is there a difference? I could say car accident, right? And everybody could picture something different, okay? Car accident is also a fender bender. That's a car accident. And it's also somebody getting T-boned, slammed. But they're both car accidents. Okay? So the mechanism of injury makes a difference. When I get on scene and I find out what happened, that's the mechanism of injury. Right? And it really makes a big difference. Okay?
So how are you more specific in the mechanism of injury in describing it then?
Like in a T-bone.
I'll just say, you got slammed by a truck or
Addressing
you
it.
got touched.
Right.
Addressing
It's simple. This is not medicine. This is just, how we utilize this statement. Inability to control external bleeding. Obviously, if you can't control it, we're going to teach you methods how to control it so that it doesn't stop on its own, right? So so we're going to get to all this. All right. Very important slide. Very, very important slide. You got to learn this, you got to know this, you're going to be tested on it, etc. Okay? So, you've got to know the characteristics of and the differences between an arterial and a venous bleed. This is important in the field, this is important in testing, this is important in your class. You must be able to know the characteristics of the differences between an arterial and a venous bleed. Very simple. An arterial bleed, number one, will be bright red. Bright red. Why is it bright red?
Oxygen.
Well, very good, because it's got oxygen in it. It's mixed with a lot of oxygen. It causes it to be bright red. Okay? I remember a story, 20 years ago, somebody called me, Erev Shabbos, my wife cut herself and is bleeding, there's blood everywhere. And I said to him, what color's the blood? And he said, what do you think is red, you moron? And I'm like, no. Describe the color of the blood to me, all right? They don't understand, right? Lay people just don't understand. To them, it's bleeding and it's red and that's it. No, it really makes a difference. You can see the difference. Arterial bleed is bright red, okay? Also, the other thing that they're going to ask you to know the difference is that it spurts. Why does it spurt?
From the heart.
Pressure from the heart.
Right, because it's connected, right? An artery is connected to the heart. So if you come in and you see, boom, right? You shouldn't count how many spurts there are in a minute to get the heart rate, okay? Would that be an accurate measure of the heart rate?
Yes.
Would it be?
Yeah.
Yes, absolutely. It would be perfect. But don't stand there going, 1, 2. Don't do that, okay? However, theoretically, it would be accurate. Because every time that thing spurts, heart's beating. That would be the heart rate, okay? So yeah, I've walked into rooms, bathrooms, where they painted the entire bathroom in blood, literally. Okay, it sprays everywhere. Okay?
Is
It's
it
a
a
mess.
lot or it's just
What?
is it a ton of blood coming out or it's just a little bit but just moving?
Right, first of all, it depends on which artery got cut.
Right.
If you cut a real small one, but if you cut a big one, whew, it's gonna, yeah, sure. So, know these two things, guys, know these two things. Bright red, spurts, okay? Venous bleeding, two things. Dark red, more of a maroon, okay? Dark red, deoxygenated blood.
When they take your blood at the doctor, that's that color.
That's that blood. Very good. That's venous bleeding. That's venous blood. Yes. Every IV that we put in pre-hospitally is typically going to be venous blood. Now, sometimes in the hospital, we'll take something called an ABG, which is an arterial blood gas, and that's where we actually pull blood out of an artery. Okay? But that's not a common day-to-day thing, and you won't see that in an EMS situation.
Is there a reason that you specifically don't take oxygenated blood rather than?
The reason is that we give medication through that IV,
It's on its way to the heart.
and we want to send it to the heart.
Okay.
So we always want to
You
go
always want
into
the
the
medication
vein.
going to the heart?
Yes. Yes. It has to. How
No,
else is
but-
it going to work?
Well, if you, there's something happens, if you're putting it in the arterial blood, then it goes through the whole body system.
Yeah, but till it gets back to the heart, no, it doesn't work like that.
No.
Medications
If I'm putting it right,
typically
if
go
I'm putting
into
it
the
right on
vein.
the, right through here, you know, it's, but it, you know,
It's
it
gonna
goes straight
get,
to
it's
the
gonna
leg.
be, yeah,
Or
but
to the
who
foot.
said it needs to go to the leg?
It's gonna go everywhere. If you
It's gonna go everywhere.
You want it directed.
But we wanna
Yeah.
usually get it to the heart,
And then it'll go into the main.
Yes.
Difference.
okay?
Here it is, right, these are the colors?
Very good,
Show the video.
very good. This side,
Careful, don't
too close. Colors, right, okay? So arterial bleeding, two characteristics, yes?
Bright red and.
Bright red and spurting. Venous bleeding, dark red, and it will flow steadily, like opening a faucet. It will just flow, okay? And the reason for that is it's not attached directly to the pump. It's just moving, okay? It just moves, all right? So these are the two things you really must know.
Is
Is
there
it all-
is there a difference? Meaning, yes, you can identify it, but there's
Meaning
a,
Is there a difference in treatment? No. Is there a difference in how long this person has to live? No. Again, I can't
so just
explain why they want you to know these pieces of information. There's a lot of times you're gonna want to ask this.
Is it,
An
is it
artery
more
must be
dangerous
hard.
for arterial bleeding, like you have less time?
Theoretically, yes.
It's
But
coming
it's
out.
spurting.
Theoretically,
Close it.
But if you
But-
have a larger
but there are-
venous cut than a
there
small
are
arterial cut, it's
people
worse.
exsanguinate, that's the medical term, to bleed out from venous bleeding just as well. So don't think it's like, less serious, okay?
Can you
Is it all
stop
the blood
artery
being
bleeding?
I have a quick story. I don't like to do too many war stories, but I have a great story. Friday afternoon. It's always Friday afternoon, right? It's like the Baal Shem Tov stories. We're all Matzah Shabbos. Mine are all Friday afternoon. Erev Shabbos. So, great story. Get a call for somebody's bleeding. It's literally on my corner of my block. All right, I'm the last house. There's a building, and apparently the patient's right next to it. Okay. So I jump over there, go over there, and all of a sudden I see on the floor this flood of blood. Okay, all over the sidewalk, bleeding, unbelievable. I mean, a thick, wide sidewalk, and it's covered. I'm like, what's going on? So I see that there's a Spanish-looking lady sitting on the floor, bleeding out of the back of her leg, and then she doesn't speak English. It's okay. I spoke to her in Spanish, and I asked her what's going on. So she tells me that she works for a Jewish family on the next block, and they gave her a gift, an old food processor that they were no longer using. The problem is you don't package a food processor in a shopping bag. Okay, you know that circular blade? That's sharp. In case anyone didn't know. That's very sharp. So she's walking up the street with the food processor in a thin shopping bag and boom, slice the back of her leg. Okay? Slice nice, okay? She was bleeding. She was bleeding. All right? And that was a mixture of colors because we had both. And so, but stop the bleeding. And we're going to talk about that. That's what your job is. Stop the bleeding as soon as possible. All right? Capillary bleeding, this is a bleeding you're all familiar with. All right? All the bleeding that you are familiar with, whether it's a nosebleed, whether it's a paper cut, whether it's falling over, And we're going to learn terms to describe all these different types of cuts and things. But all the bleeding you've probably ever seen in your life has all been capillary bleeding. All right? Capillary bleeding is type of bleeding that is pretty self-limiting, which means it will fix itself. You may need to put something on it. You may need to wash it under cold water. You may need to dry it and put a little pressure or a Band-Aid or whatever. That's all fixed and
Is that
fixable.
because it's more towards the surface?
Yes. The capillaries are right under the surface of your entire body. And they bleed a lot. But they're so thin and tiny that
Capillary blood would be similar in color to the arterial.
it could be either. Because capillary has both, remember? Has two ends,
It depends where.
so it's sort of a mixture.
Wait, so there's veins, arteries, and capillaries that carry gases throughout the body?
No, veins, arteries, and capillaries carry blood throughout the body. Capillaries do not transport blood. They are the destination.
The end.
That is where the artery brings the blood to, and the vein takes it away from. The capillary will be in direct contact with a cell, a tissue, or an organ. Okay? Just think of it simple. Think of, here's the organ, and then there's a capillary that runs right along, right next to it, touching it. So the gas can jump, it's like the bus stop, the bus terminal. The gas can jump off into the organ. The used CO2 can jump out of the organ into the capillary, and then it continues to flow back into the venous system. The capillaries are not for transportation of blood, they are for
Housing.
gas exchange.
So it's constantly, in every area,
Everywhere in your body.
it's constantly exchanging.
Yeah.
Oxygen is only exchanged by organs?
Capillaries. Capillaries.
So I'm saying only organs need
No
oxygen.
tissue,
Like, let's say your dermis and epidermis.
yeah, they need also.
So you have capillaries all over your body?
Everywhere. You ever saw a little kid bang their head in school?
No, it's only, whether it's only.
Do you ever see that? You ever see a little kid bang their head,
Oh, you gotta watch.
get a cut?
Yeah.
Happens in yeshivas in schools all the time. They bleed, there is so much blood, okay? And the teacher, the mora, freaks out. There's blood like you just performed an abortion, okay? There's blood everywhere. The kid is covered, the mora is covered in it, there's blood everywhere, okay? And in my experience, which is quite a lot, I tell the teacher, I said, put on some gloves, take the kid to the bathroom, get all the bloody clothes off, clean it. Clean the child. Wash him down, okay? Wash him down. And it happens every time. The cut is about yay big, okay? It's that big, okay? But from the head, with his surrounded, complete, there are so many capillaries, more than anywhere else, filled with them. This tiny little cut, kid will bleed all over the place, okay? And as soon as you take off the dirty clothing from the child, and you wash them down, and you get the blood off of their arms and their face, and the child becomes a different child. Right? This is called psychological first aid. We don't really teach much of this, all right? But I've done it so many times, and you'll see the cut is about that big, you know. And the teacher thinks that they need surgery, and you know, all sorts of stuff. You know, and really, they're all good, okay? Just gotta clean it up. Just gotta stay calm and deal with the problem. All right. So capillary bleeding sometimes can take a while to stop. Nosebleeds. All right. Everybody freaks out with nosebleeds. Reckon if you can stop a nosebleed in 20 to 30 minutes, you've done well. If they don't stop before that, really. Okay. Especially if they got a good zets. You know. They.
Capillaries in the nose?
Yeah.
Anywhere.
Yeah.
Anywhere.
All over. Okay.
But it's part of the head.
They bleed, okay? And people always, it's not stopped. Like, how long are you holding, you know, the nosebleed? Oh, at least 3 minutes. Well, yeah, call me after 30 minutes, okay? 20 minutes is the average. They bleed. They take a long time. You have to have a lot of patience. Control of external bleeding. We'll talk about some of these concepts, all right? I think I changed a couple of these slides from the way you have it, so if there's any change, go with the board. Okay, BSI, do we know what that stands for? Body substance isolation, you can use PPE, wording, get used to both. So direct pressure, this is the first stage in your stopping external bleeding. Direct pressure. We use sterile 4x4s. You can use one sterile and a bunch of non-sterile. I'm not getting into all that. Typically on the ambulances we use sterile dressings. You open up a bunch, you take them and you place it with your gloved hand right over the bleeding site. Okay, this is called direct pressure. We're going to do this on practical skill nights, so I don't want to get into too much detail. It's much better to do it. What's that?
How are you gonna be practical like?
We'll cut someone and
A
we'll.
little bit, maybe a little bit.
That's what the,
Dummy.
is that for.
No, you're going to do it on each other, all right? Okay, we're going to simulate that maybe somebody's bleeding, all right? So, direct pressure is number one. Number two, pressure bandage. You can put a line through this. No, sorry, the pressure bandage is still in. I took out the thing that's not in. Good. Pressure bandage. We're going to teach you.
Skipping
What?
Elevation.
Yeah, that I took out. We're going to teach you how to do a pressure bandage. I'm not talking about it tonight. We'll teach it to you on a skill night. You will all be proficient in making a pressure bandage, okay? It's a simple skill. We'll teach you. We're going to splint it if needed. PRN. Let's learn this, Rosh Hashanah. Let's learn this. PRN.
Skipping elevation board.
Yeah, if I took it out, I took it out for a reason. Right, I took it out.
It's on the board, yeah.
It's on the board, elevation on the board.
Okay.
I already crossed it out, so please take it out.
Good. What I did was I made these in small.
Not.
Yeah, I didn't delete them, I just made them in small.
We don't need another.
They're not part of New York State anymore. Okay?
Is it good to elevate?
We don't care.
Machlokes HaPoskim.
Are you in New York?
The book says that they don't do it anymore.
Right. New York State took it out, so what I did was, instead of deleting it, I just made it in a small font and I ignored it.
In South Africa, they elevate.
Oh. South Africa. But what happens in South Africa stays in South Africa, okay?
Not HIV.
Alright. What?
Not HIV, is it?
That doesn't stay. That got out. A lot of monkeys, I told you the other night, Let's learn PRN. PRN is a good medical acronym, Rosh Hashanah to know. Okay? Hope they speak Yiddish in Santiago. PRN. PRN, I made up a way to remember it. Per required need. That's not what it means, but it works. PRN, per required need. If a doctor ever gave you a medication and said, you know what, if you're getting that itch in your tachas and you want to take one of these, you could take one then. Okay? That he wrote on the script to the pharmacist, PRN. Okay, PRN, per required need. That I made up. It really stands for, you want to know the Latin? You don't want to know. Pro renata. Okay, but you really don't need to know that.
You don't need to know.
You don't need to know that, no.
We need to know pure required per.
You need to know what PRN means. PRN is a word that we use in medicine a lot.
When necessary.
Okay? When necessary. When needed. Okay? We use it a lot. Okay? That, Jackie Mason says that every prescription from a doctor, nobody can read it. You know why? Because they all say the same thing. It says in code, I got my money, now you get yours. That's what it says. So, it's not really true, okay? There's really some, seichel behind it, but I'll teach you some of the words that you will see on these type of things. PRN we use a lot, when needed, okay? You need to document, when do they take their Viagra medication? Do they take it every day, twice a day, 4 times a day, or when they need it?
No more than 6, though.
Right, prior to.
Okay?
This.
I'm saying, it's not a joke, it does mention that a few times in the book.
Well,
When they
That
take
if
it.
they took their Viagra or not, because sometimes they won't be
We
honest
will
about it.
talk about
Because it
that.
causes a different
It affects
heart rate.
treatment.
Yeah, it will affect treatment. You're going to ask male patients if they took Viagra. We'll get to that later on, not tonight.
I know, you put in the report how often they
4 to
take
4
it.
hours.
Yeah. You're gonna put in your
Last time
report,
they
thank
take
you.
a sample.
Thank you.
It's
You're gonna put in your report how often they take the medication.
And when the last
So
time
we
they-
have short ways of writing, once a day, twice a day, 3 times a day, 4 times a day,
When needed.
right? Or when needed.
Yeah.
So this is one of the acronyms that would be used, okay? PRN. So splinting, we're not talking about tonight. It is a practical skill night. We're gonna teach you how to splint one thing or another. Let's talk about tourniquet. Tourniquet has had a very interesting history. When I became an EMT, we were able to use tourniquets. Then it was completely banned to use tourniquets, and now they're back in flavor of the month, okay? So things move. We learned from the military, okay? They were using them, they've always used them, it always worked. I'm not quite sure why in urban New York we were so scared of them. I know why they were scared of them. The theory was that if somebody had a tourniquet placed, they would have to amputate the limb. That was the scary part. It's not true. You have 4 to 6 hours, okay, which even by military standards is way longer than they ever need to get to an OR. Okay, I think the military can get somebody from a battlefield to an OR in 45 minutes. Okay, if you're living in New York City, you can get from the battlefield to an ER in less than 10 minutes. Okay, so there is no question that tourniquets are good. Tourniquets work. What do? I'm going to teach you how to do it again on a skill night, not tonight. In short, they occlude the arteries. They cut off arterial supply distal to wherever you put it on. Okay? That's it. So you put it proximal to the injury and tie it real tight, and we'll show you how to make one out of EMT paraphernalia that you carry in your bag. We'll show you how to use the military one that most ambulances, but not all, are carrying. And that's it. You use tourniquets. Okay, we're going to teach you how to use it.
When they take blood at the doctor's office.
Okay, very good. So I was waiting for this question. When they take blood at the doctor's office, so if you're an old fogey like me, right, and people of my, number of days doing this, you call that a tourniquet. The problem is it isn't, okay? So now we have a new name for that. When I teach medics, I teach them that is called a VCB, a venous constricting band. That's different from a tourniquet, by definition. When they put that on at the doctor's office, or when I put them on, my patients, that's a VCB. What am I doing? Venous constricting band. I am occluding venous flow. Veins are higher and take less pressure to occlude. All right? So when I put on one of those, you're not like tingling in your fingers, or you shouldn't be. There should still be arterial flow. All right? If you don't have, or it turns white, or whatever, it's too tight. Okay? It's just supposed to bring the veins, pump the veins up a little bit, so you can actually see or feel more, to be more exact, where you're putting the needle. A tourniquet has to be so tight that when you feel the the distal pulse, it's gone. Then you know you put the tourniquet on right.
Blood pressure.
As is the spurting bleeding.
So is
The
that?
blood pressure
Right, the
cuff.
bleeding will stop
A
too.
blood pressure
What
cuff
do you
is
say
a
about the
tourniquet.
amputee?
We'll talk about how to use it.
That's what it is.
It is a tourniquet, but I don't
They-
teach you to use it as a
Well, they
tourniquet.
said in last resort, they said to do that, to
I don't
use
think
it.
it would work very well.
It needs to get to the operating room, to the OR. You have about 4
They said if you don't have a
hours
tourniquet,
until they'll
you
lose the
use
limb.
You're supposed to write the time on it.
It will be removed.
set.
We'll talk about it. Here, watch.
Wouldn't that be the radial pulse?
No, but distal to the.
Distal to wherever.
Distal to the injury.
That's what
So
it
this
is.
is, oh yeah.
Okay? Give oxygen as necessary. We'll talk about that. And treat for hypoperfusion. And that's what we're working up to understand what that is. Alright, splints. There are different types of splints. We're going to talk about splints a lot when we do fractures, musculoskeletal injuries. Not tonight. Okay? Here, applying the tourniquet. Alright? So it's very important that you write TK, the tourniquet, and the time. Typically, we used to write it on the forehead of the patient. Okay? Because you assume that the forehead of the patient will remain with the patient, right, as opposed to some piece of paper or tag or whatever. On the military cat tourniquets that you see today, they actually have a white
Label.
label sticking out,
Velcro.
and you can, no, the label's sewn in, it's not Velcro. That you can't take off. Okay, it's part of the tourniquet. So you can write it on there.
The idea is that when he comes to the hospital.
Yeah, they know exactly,
forget
yeah.
No,
What
like that,
time?
it's on
So
the.
they know that the
Velcro
4 to
is-
6.
Right.
Yeah, but you can't
Right,
remove
right,
it.
the time
Yeah,
also,
but
I
it's still on
think,
the
is
Said
Velcro.
and time and place.
Okay? Alright, let's just talk briefly about internal bleeding. Briefly about internal bleeding, alright? So, we have something, come on, sir.
Thank you.
Oh, it's good. Thank you. So is it,
How are you? You're strict EMT, by the way, just for,
It's okay.
Okay, we have internal bleeding, all right? So let's talk about internal bleeding just briefly. The mechanism of injury may lead you, well, let's define internal bleeding. Let's define it, right? You don't see any blood, okay? Very simple. You don't see any blood. They're bleeding, but you don't see any blood. Remember I told you when we discussed the pelvic cavity, remember I told you that there was a lot of space for blood to pool, okay? The opposite of the pelvic cavity would be the cranium, right, where there isn't space for even one drop of blood outside of the vasculature. No space, okay? And that causes all sorts of head injuries that we'll get to. However, there are parts of the body that blood can pool in and you won't see any blood, okay? So, rigid or distended abdomen. We're going to teach you how to palpate an abdomen. Every patient has to have the abdomen felt and checked to see if it's rigid, if it's hard, or distended, means bloated more than usual, okay? We don't want them to have a rigid abdomen. One reason for a rigid abdomen could be internal bleeding, blood pooling in there, all right? Bruising, if there's major bruising on the body, bruise typically is just burst capillaries under the skin, but what's going on underneath that, okay? We may not know. We may need to get imaging and find out. Broken bones. You will never know if you have a broken bone inside a patient's body and you don't see anything. All you see is a crazy deformity on an arm, a leg, right? Do you know if there's a blood vessel that's been ruptured inside? You have no way to know. No way. Obviously, if you see huge amounts of black and blue bruising, that may give it away. However, you may not know. You may be too early to even see that. So broken bones can often come with internal bleeding. This one's a good one. Coffee ground emesis. Okay? if you see somebody threw up and it looks like Folgers in the morning, the crystals, literally, it looks like
The actual.
the actual coffee prior to making
Grains,
it.
the grains.
The grains, all right? If you see that, that's internal bleeding. That's a sign of internal bleeding, okay? Where, what, how, who, we're not getting into. Just know that coffee ground emesis is one of the things that you would, rectal bleeding.
What color is it?
Yeah, it's
Coffee like color?
Yeah, rectal bleeding, okay? I once had a Rebbe in a yeshiva who collapsed in the lunchroom, and he must have lost about 2 liters of blood rectally, okay? The first thing I did when I walked in, I said, get the mechitzas and surround, that the kids shouldn't see this whole situation, okay? Massive rectal bleeding, and he was just going about his business, doing his day, okay? He's in the lunchroom and boom, lost about 2 liters of blood.
What was the mechanism of injury?
It was an ulcer or something, a GI problem that had burst and just boom, just took him out. He had no blood pressure, was unresponsive when I got there, okay? So, it happens. Don't think these things don't happen, all right? They're rare, but they happen.
Hemorrhoids wouldn't cause
No,
such
no.
extensive.
Hemorrhoids is a bright red. It's good you brought up. Hemorrhoids are bright red bleeding,
Does this come from the capsule?
and it's capillary bleeding.
Oh, I
It's
know.
not life threatening.
I know. If you want, we can do it by the skill night.
But hey, I gotta say one thing about the bleeding from hemorrhoids. The medical word, and I'm not making this up, the medical word for the bleeding that occurs from hemorrhoids is hematochezia. I kid you not. Medical word, look it up. You'll remember that. But come on, how good is that word for us? Come on.
Ton of bleeding and then you collapse. What is there to do? Meaning the blood is
Well, we didn't get to what to do. We don't know.
Still at the,
Take it easy. Nausea, vomiting, especially when there's blood, right, in the vomit, and dropping blood pressure, late sign, we'll talk about that soon. Treatment for internal bleeding, okay? Maintain the ABCs, right? So they were telling me this on the way, they were reading about this, right? Maintain the ABCs. Whenever we say maintain ABCs, means keep them alive. Airway, breathing, circulation. We're going to learn more in depth how to deal with these things, all right? Control external bleeding. So the treatment for internal bleeding, is to control external bleeding.
Meaning don't let it drain.
Right. If they're bleeding, stop it. Okay? Stabilize the patient based on mechanism of injury and transport. Okay? Because it's internal bleeding, you have a high index of suspicion that they're bleeding. I'll tell you the best one for index of suspicion is an elderly hip fracture. Okay? This one, I always have high index of suspicion that they have internal bleeding. Always. Whether they do or they don't, doesn't matter. I come in, I see an elderly, I see the hip fracture, that's it. They've got internal bleeding, till proven otherwise. And that's really the way you want to think about it, because hip fractures can kill. Okay? Not because of the hip fracture, not because of the bone or the pelvis or anything, no. Because simply, remember the anatomy that we did, that I showed you, the huge veins and arteries that run, right? That is the aorta as it splits off, okay, to the iliac crest. That is as big as it gets. Those are the biggest arteries, okay? That's like, it's smaller than the aorta, but it's right out there, okay? Those are, so if one of those gets nicked or cut or whatever, and you'll never see a drop of blood. It'll all bleed into the pelvic cavity, and you won't know. So elderly, especially elderlies with a pelvic fracture, are very serious calls. And they need to get transported to a good trauma center, and it needs to happen quickly.
What age is considered elderly?
You decide.
The guy's 50.
Yeah.
Done, Nate, good job. You just decided.
Rule of thumb, guys.
What?
Severity of bleeding, we spoke about this here. Here's your blood donation. Whoever brought that up earlier, okay? When you donate blood, first of all, do you know how many people faint?
Sure. Most women.
Well, let's not get racist here. Take it easy, that's my job.
Same thing.
People faint because they lost a liter of blood, and now they feel, that's why they don't just give the donuts and the juice to entice you to do it. There is actually a reason.
Scam.
Yeah, there's actually a reason for the donuts, okay?
Why don't they give you a steak before to get the iron up?
Okay, but you're still gonna
Lack of sponsors?
have a problem when they pull a liter of blood. Okay, it's still gonna be a problem. So the fact is that it's taken really
I was
slowly.
gonna say women that are, not having their period, they shouldn't be donating blood. Because they're losing blood during that time anyways.
I don't know. I never heard that one.
You made that one up.
No, it's not.
I said I don't know. Okay, so sudden loss. Okay, we're talking about major trauma.
We have 5 minutes to take the pizza?
Yeah, let me see where I'm up to.
Okay.
Yes, right now.
So I'm also pizza.
Turn off the camera.
How much,
Pause.
how much blood, how much blood is someone giving like
The red?
at the doctor's office when they're doing
No, when you donate blood, when you donate blood, how much?
The red button.
I guess eventually you're gonna explain what all that stuff that you
Yes.
said.
Am I gonna need to take that?
What are those things
Click
right?
power.
Too late. I swiped.
Do I need to take this audio and that video, put it together before I render and upload to YouTube?
Let's see what he wants. What are you doing? I'm just doing it for safety. It's recording, just put it down. It's
Either
recording.
that, either that or blackmail.
Okay, here we go. So
2TC right now.
we're back after pizza break. Apparently that was important. Is the pizza better than last week's?
Same place?
I don't know.
Anybody know? Gino's?
This was pretty good.
But-
I mean, not trying to.
It tastes like pizza pies.
He's the pizza man, I'm the banana man, okay.
Did the same pizzas last week? Or I'm trying to figure
Who's
out.
the flations guy? That's who I need to speak to. Alright.
Next week we can inflations.
Oh, he could be my friend.
He's still Felicia, that's why you have a slice.
Could you go back one slide, just do the last one you didn't do, just to explain it? The
Yeah.
blood volume loss slowly?
Oh, I
Yeah,
explained
blood
this.
donation.
Slowly is like when someone gives blood, like a donation. Otherwise, trauma, when they lose blood really quickly, rapidly.
But over what period of time? When you're saying sudden blood loss of 1 liter, over how long?
When you give blood, it takes about 30, 40 minutes.
No, it takes 15
What?
minutes.
Like
15 minutes, that's slowly.
Anything quicker than that is.
Yeah, it's fast. Alright, so now we're gonna get to tonight's lecture. Okay, now we're gonna learn what we're here to do. All this was really just review. There wasn't much new. Okay? Now we're gonna get into perfusion. Alright. This is a good definition, and this is what we're going to use. We understand the purpose of blood. What is the function of blood? All four components. The function is to transport gases and get it all over the body, to every single cell, organ, tissue, etc. What happens when we cannot, for whatever reason, we cannot get blood to every single cell, tissue, organ, etc.? What happens?
It dies.
Well, we don't die straight away. We go into a state called hypoperfusion. What does hypo mean before a word? Okay, hypo means low.
Too little.
Too low, yeah, little or low. Learn this, we're gonna use this word a lot. Hypo, low. Hyper,
Too much.
a lot, too much, okay? We're gonna use these a lot, hypo and hyper. So perfusion means getting this blood to every single part of the body, whether it's cell, organ, tissue, it doesn't matter, okay? Hypoperfusion is for some reason, whatever that may be, right now it doesn't matter, we cannot get blood to every single part of the body. And that's hypoperfusion. That is the medical term for what is known as being in shock. Okay? The terms are interchangeable, they are the same thing. It has nothing to do with an electric shock, and it has nothing to do with you waiting for your buddy to come around the corner and go boom, and he goes, ah! Right? There's nothing to do.
Why are you saying why tissue? Inadequate tissue perfusion.
Because
Perfusion happens.
cells make tissue, tissues make organs, organs make systems, and systems make humans.
You didn't figure it out from this time?
Inadequate tissue. Okay.
Okay? All your organs are built from tissue. Okay? So, this is the key word here. Hypoperfusion. Low level of perfusion.
Which means there's not a lot of circulation around the body?
Which may mean that. Okay? We'll get to it. Here's a picture of, it's not very important, just a way to understand. Do you see, let's take this one, right? It has an arterial end and a venous end. See?
What is this?
That's a capillary bed.
The exchange is happening.
Okay, so it came into the capillary bed all nice and red, full of oxygen, and then it goes into the organ, let's say, or tissue, it doesn't matter, and then whatever the organ or tissue has in it, CO2, that jumps into there, and then it goes into a vein and continues up into the superior inferior vena cava. Okay, that's just how it works. Okay, now turn to your other book, the dark blue one. Okay? And this is a chart that I created to, students had a very hard time understanding shock. What page is it on that page?
It's in between, it's a non-page.
Okay.
It's in between 14 and 15.
It's between 14A, 14 and a half.
14 and a half.
Okay? Now, I made this chart because students were having a very hard time. It's not that complicated, but you do need to understand it.
Stuff.
Okay. So, in order for the heart to work, in order for the body to function, we need three things. In slang, I call them pump, pipes, and stuff. We'll talk. Okay? Pump, pipes, and stuff. That's not medical. All right?
Oh.
That's my words. Okay? So, think of shock as there's a problem with one of these three things. Is it a pump problem? Are there a pipe problem? Or is it a stuff problem? If one of these three things is failing, this patient may be in shock. It's that simple. Now let's bring in some slightly more medical terms. So, the pump is obviously the heart. That's it. The pipes are the vasculature, right? Whether it's veins, arteries, doesn't really matter. Let's just call it the vasculature. That just means the pipes. Okay? And the stuff, most people would say blood, but I want to say blood and fluids. Okay? Bodily fluids. I don't want to just get tied into blood. Predominantly,
It is blood.
It is blood. But I want to bring in body fluids also, and I'll explain why
What
later.
about that? What is either clotted or
They can
something?
be the source of the problem.
No,
Oh, you're saying that's the
just,
source?
just stay with me. Stay with me. I will answer all your questions. So again, someone's going into hypoperfusion or shock. There's a problem with one of these three things. Either the heart, the pipes, the vasculature, or the stuff, the blood and bodily
Is
fluids.
there a sign that they do?
Hold on, hold on.
Slow it down, Sal, slow it down.
This is really important. I'm going a little slow because I want you to understand it, all right? Now, there are specific names for the categories of shock that occur when there's a problem in one of these things. Okay? Do we all understand? I'm taking it for granted that if you understand that if you build a 100-story building and you want to get water from the basement to the top floor, are we all in agreement and understand that we're going to need a pump, pipes, and the water to get up there, right? We understand that we need these three things. So the body is the same thing. It's just a very complex building, and we need to get this stuff, let's call it blood for now, all the way around and everywhere, right? Make sense? Good. So if there's a heart problem, and there's only one that has an actual pump problem, the type of shock is called cardiogenic shock. Remember, the word cardio is a word that we use to do with the heart. Cardiogenic shock is any shock that has to do with the heart as a pump failing. Okay? So you will hear the term heart failure. This is not a heart attack. This is the heart cannot squeeze. That squeeze, that systole and diastole is not happening properly. So there's a pump problem. Is there any problem with the blood? Did they lose any blood?
No.
No, they have the right amount of blood. Is there a problem with the pipes?
No.
No problem with the pipes. So what's the problem? That the heart isn't squeezing. This happens after heart attacks. This happens after very old age, not 50. And, just the heart starts to give up.
It's just
Yeah. So this is called, again, you got to know this word,
Cardiogenic.
cardiogenic shock. Okay? What does it say there in white?
From.
What can cause it? Should change that to causes. Caused. Right? MI. MI, you don't really know what that is yet. We'll get to it. It just means a heart attack. Okay? What's an important treatment? Oxygen. And position of transport. TXP, transport. How should you position a patient in cardiogenic shock? Well, you should sit them up. We'll discuss why a little bit later. For now, let's just get the facts.
what does the oxygen
It
do
doesn't-
at this point?
It doesn't mean the heart stop.
The heart did not stop.
It's just not pumping
It's
enough.
not pumping efficiently. We'll get to it. We'll get to more details. For now, understand this. Is this clear? Again, if there's a pump problem, the pump is called the heart. The name of this type of shock is cardiogenic shock. We need to give them oxygen, and we need to make sure that we transport them sitting straight up. That's all I want to talk about for now. Everybody got that? Right, now let's move down to this one. Stuff problem, blood and fluids, okay? So, the word we use for the type, the category, is hypovolemic shock. Let's break this word down into two words. Hypo means low. Volemic, volume. Very good, simple. Hypovolemic shock. So what does that mean? We lost volume. We lost volume. Bleeding out. Internal, external, okay? These are the most common forms of shock that you will see in EMS career. Okay?
What was that word again?
Hypovolemic. It's on the board.
Bottom line.
Now that, when someone has a limb cut off or something like that, that's where, and they lose a large amount of blood, that's what they call it.
But why they have to have a limb cut off? All they gotta do is cut an artery.
So it's a low
okay.
volume of blood.
What?
A low volume of blood?
Well, wait. This is the general term. Hypovolemic. We lost volume. Okay? Volume is lost. Now, we're going to split this into two subcategories. Alright? Look at the names. The first one, hemorrhagic. What does the first four letters tell you? Blood, right? And we know hemorrhage means blood loss, right? So hemorrhagic shock is shock caused by blood loss. Very simple. What type of shock is that? What type of shock is that? What's the category? It's part of hypovolemic shock. I'm sorry, there's a lot of words, but you've got to know these all. Especially when I underline, the categories. But you got to know the small stuff also. That's why I made this chart. It's all on one page. Don't have to read 800 pages of the textbook. It's there.
Now you tell us.
I told you that on day one. Alright.
It was really day 3.
Alright.
Book by then.
The other type of hypovolemic shock is metabolic shock. Metabolic shock. Now if you look in your textbook, certain literature today is calling it non-hemorrhagic shock. I don't like that, personally. It's like, call it what it is, It's like using a negative, it's like, call it what it is. This is what it was always called.
Double negative.
Yeah. It's called metabolic shock. It has a name. Okay, what are you trying to make it simpler, hemorrhagic or non-hemorrhagic? I don't care for that, all right? Metabolic shock. Now, what causes hemorrhagic shock? Obviously, hemorrhage. Internal, external, doesn't matter, okay? What should you do? Stop the bleeding, okay? Right? That's really all you can do. And how should you position the patient? Well, remember on day 1 or whatever, we spoke about something called the shock position. Remember that? What was the long word for that? A retarded word. No? Anybody? You're doing all this reading and you don't know Trendelenburg. Right? Remember that? Yeah, maybe? No? Okay.
Ships in Pearl Harbor. Wasn't it ship in Pearl Harbor?
May have been.
Which position is that again, just to refresh my memory?
That's with the feet up.
Trendelenburg. Supine, feet elevated, about 12 inches.
For the cardio one, sitting up, Fowler or sitting? Sitting.
Page 11.
You can do Fowlers, but not semi. Okay?
Actually, no, it does.
You said that word again?
Right next to it.
Trendelenburg.
What
It's in your light blue.
It's in the
What
book.
is metabolic shock?
I'm going to talk about it.
Earlier.
So here, metabolic shock is a severe, life-threatening form of dehydration. Okay? I don't know if you have wives that complain and worry about everything, but a lot of women, they're dehydrated, the kid didn't drink for 30 minutes, they're dehydrated, It takes a long time to get dehydrated, okay? It takes a long time, okay? And to get metabolic shock means you have to be dehydrated and vomiting, literally vomiting your guts out, and probably got a week's worth of diarrhea. Okay? So, metabolic shock means you're losing bodily fluids
At a rapid
and not replenishing.
Wouldn't you also want heat stroke?
No, different.
When we were discussing,
specific.
when we were learning about the positions,
Yeah.
you had mentioned that the shock position of the elevation of the legs doesn't always apply. And you said you were going to explain that. I don't know.
No, what I said was that if you're putting someone in the shock position, it's called Trendelenburg, the feet should be elevated 6 to 12 inches. That's it. What I said was that I and some people are discussing whether it is any advantage to use it over just regular supine.
Oh, okay.
But-
Elevation of.
But elevation of the legs is definitely within your protocol, your scope of practice, and what you should be doing right now. Okay?
Would a metabolic shock dehydration, wouldn't a patient be urinating blood also potentially?
Maybe, maybe not. No 100% definitive answer there. Okay? It's possible, but not necessarily. Right? So, we have two types of shock here. They both fall under the title of hypovolemic shock. One is the most common, hemorrhagic shock. One is less common, but sometimes seen, metabolic shock. And
Less common because by that time the person would have noticed and done something about it?
no, it's just less common. You're just not seeing it as often in pre-hospital setting. Yeah.
You didn't write a important treatment for metabolic shock. Is that like pull type of fluid?
There's very little you can do. Medics can give fluids and stuff, but I tried to keep this on an EMS,
Well, you would-
EMT
Well,
level.
realistically, we would need IV, you have to just get an IV.
Yeah,
You need ALS, you don't need.
Yeah. So you can't do that, so I didn't.
New York State.
Okay, I tried to keep this to New York State EMT, what you're allowed to do. Alright, here's the big one. Ready? Pipes. I want to draw something over there. Just, you don't have to look very long, just turn your bodies, you don't have to turn. I just want to draw something really quickly. Here's a normal, healthy, perfectly good artery, okay? And guess what? It's filled with blood, and it's putting a nice pressure on the arterial wall, and all's hunky, right? Okay, something happens to the body, I don't know what, doesn't matter, and for some reason, the artery now looks like this. There was no bleeding, there was no loss of blood. So where's the blood now?
Less
missing?
There's no pressure.
Right.
Empty hose.
Right, but there's no loss of, do you understand? There's no loss of blood. They're not bleeding out. Okay, it's a closed system,
Yeah, the artery dilates.
all's good. But here's the artery, and now here's the artery. Something happened that caused this.
Back up.
I didn't say what.
Disappeared.
No, it kept
It
just
opened.
It got dilated. It's the same amount of blood. Okay? I didn't say what happened. I said something made the artery jump from normal, healthy, nice to this. Dilation. Okay? This is what we're going to talk about now. Everybody understand this? Simple. Good. Alright, so these shocks, all these shocks, where this phenomena occurs, have the title distributive shock. Gotta learn this word. Distributive shock. Okay? All of these shocks have the same title. They all are connected to the pipes. Okay? Or the vasculature, if we want to talk like grown-ups. Okay? And what does it happen? Why does it cause it? Widespread vasodilation. Widespread vasodilation. This is not one artery that has just suddenly got larger. Widespread, systemic. Across the whole body, the arteries have decided to go from that nice skinny artery to that big wide thing. Okay? Now obviously I exaggerated, but to make the point. Okay? Alright. In distributive shock, there are a number of sub-shocks. You need to know all of these. Okay, so listen carefully, and let me tell you what I need to tell you. Anaphylactic shock. Alright? This is a life-threatening allergic reaction, and we will do an entire lecture on this later on in the course. Not tonight. Just understand that anaphylactic shock is a problem, a distributive shock, a problem with widespread vasodilation, and we're going to talk about it later in the course. Yes?
Doesn't it close up an anaphylactic shock as opposed to
Swells.
dilating it?
It's dilating, that's what it causes.
What's
Airway.
dilating?
It's dilating, therefore you can't breathe.
That's why you can't breathe.
Your arteries are expanding, they can.
Guys, listen. Septic shock. Septic shock. This is an infection that has run out of control. Okay? Septic shock. This is an infection that pretty much, just think of it, it took over the body. Okay? Again, the same sort of problem, vasculature, pipes, problem. Okay?
So they all have the same symptoms?
No, well, no. Just, they're all,
So
They don't
same
have
signs.
systemic vascular dilation?
yeah, they're all caused by
Caused by Systemic vascular
Va-
dilation?
vasodilation,
Okay.
yeah. But the actual signs and symptoms that you see will be different.
Uh-huh, okay.
Okay? Neurogenic shock. So as EMTs, I'll teach you very simple. Neurogenic shock, you need to get a trauma to the CNS. The patient needs to get a trauma to the CNS. What is that? Central nervous system. That's it. That's as far as deep as we're going with neurogenic shock. So, alright, let me just do the last one. Psychogenic shock. This is the famous one. This is fainting. Okay? You ever had blood drawn and you fainted? Okay? From a drop of blood. You're not fainting because they took one vial of blood. You're fainting because you're scared of the needle and the thought of losing the blood and whatever it is. You ever I don't know, I end up at these things, but if you ever go to a levaya, sometimes people faint when they see. It's anything that you see or even hear, sometimes smell, something that's really bad to that person, and they just faint.
Does it have to lead to unconsciousness, meaning
No.
would it be a panic attack and they still?
No, panic attack is happening for a different reason. This is, you see something, I'll give you an example.
Don't pass that one back.
I'll give you an example. I'm in the country, and a little child, must have been 4 years old, riding the bicycle, went down over a cliff, hill, whatever, right, and scratched up the knee, bleeding. It's a mess, okay? Child's 100% fine, except for the knee, okay? So there's me, and there's another member, EMT over there, and we're cleaning up the knee, all right? We're working on the child. Unbeknownst to us, in comes mom from a door behind us, opens it, sees her child with the knee, you know, all bloody and nasty and whatever, she goes down. Healthy, young mom, no medical problems, absolutely fine. She collapses, okay? Now, the good thing about psychogenic shock is it's self-limiting. It will fix itself. So if they're laying down, that's where you want them. If they're not laying down, lay them down. Okay, elevate the legs.
What happens there is that blood pressure.
What happens there is that there is this massive, widespread systemic vasodilation that just happens because of what they saw or heard, and it rights itself.
So blood stops going to the brain, they faint.
It's not that it stops going. It's that there's no pressure to cause your systolic and diastolic, to cause your blood pressure.
Right, but
So
less
what causes
pressure
the pressure to
in,
stop?
it would make it, if there was less pressure in their digestive system, they would throw up, but they're fainting because there's less pressure going to their head, I imagine.
It's systemic.
So it's everywhere.
Why isn't it dangerous?
Because it fixes itself.
Quick, usually rather quick.
Okay.
It's more dangerous for the trauma from the faint.
For the
Yeah,
From the
very
fall, they can bang their
often
head.
they can fall and bang their head, and that then becomes a problem. She was fine. She, fell, whatever, EMT was there, grabbed her, caught her, whatever it
There's
was.
no further treatment. Somebody faints, you just elevate their feet and give it a minute.
Yeah, they're usually okay. As long as they come back to themselves. Again, as long as you know why it happened, right? You can't just have a guy walking down the street and fainting and saying, oh, he just syncopized, no, he'll be fine. No, it doesn't
He thought
work
of
like
something
that.
scary.
You have to have You have to be able to document, even to yourself, you have to be able to rationalize why it happened. With this case, I know why it happened. I didn't just let her walk out. We checked her vitals, I checked her heart, I asked her questions about her medical history. No, of course, you work them up. But if you can work them up and everything is negative, this is the reason that, we witnessed it.
Right.
We witnessed her walk in. We witnessed her fall. So come on.
How many minutes would it take for a fainting patient to come back?
It depends. It depends. How high is the Chinaman?
Would you do vitals right away?
No, that's a statement, not a question.
Meaning, if the patient has to come back in 25 minutes, are you like, okay, let's just wait it out?
45 minutes?
Yeah.
No, we're talking about 2 minutes.
But when she goes down, do you take vitals right away?
No, when she comes back. It's all happening within 2 minutes.
This whole thing of pouring water on the head is all.
No, this is I call it the baptisms. They do it in shul by us. Woman goes down, they're pouring water, they're baptizing them. I'm like, dude, wrong religion. Okay, stop. We don't do that. And it's the worst thing because I'm going to teach you soon that one of the most important things we want to do is we want to evaluate the skin. Yeah. Guess how you're evaluating the skin when they're soaking wet because they took a Nagelwasser thing and they're pouring water on them, right? Yeah, not good, but everybody does it. Everybody thinks, oh, we helped.
Hollywood.
Because everybody thinks it's heat stroke.
In the hospital, they said that they all the nurses, they carry little ammonia packets. They smell.
Ammonia we used to carry like 100 years ago. We sort of decided that it really wasn't very good to rapidly wake people up. The question you have to understand is, from our
Why are they
perspective,
fainting?
what's wrong with being unresponsive? I always ask this question to classes. Is there anything wrong with being unresponsive?
Well, it depends why they're being
Yeah,
unresponsive.
right.
And over here,
You knew what it was.
So, fixing that part isn't really fixing the cause, or, so you're just bringing them back around, but
sooner than they should be.
One second.
brought back around.
yeah.
What is the unresponsiveness? What is that state?
That state is that you're breathing, your heart is pumping, everything's
So
working.
why can you not respond?
Because you're unconscious.
Why?
Because there wasn't
Okay,
enough-
so there's a
there wasn't
reason
enough
why.
Right, so there's a
ongoing-
reason.
But bringing them back with ammonia doesn't really help you, and you're not allowed to carry it anymore in EMS.
Makes you throw up.
No,
Whatever, it's not carried.
no, my point is that when a person is unconscious, there's a deficiency somewhere causing that.
Yeah, but waking them up doesn't replace that, doesn't.
Does that? I don't
No,
know.
Doesn't fix that deficiency.
It's fixing it itself. It just wakes them up and they have the
All right,
deficiency anyway.
let's focus. There's still a lot to do. You will be tested on these. You'll be tested on this. Seriously, you gotta know this. You gotta know the difference between the different types. If they talk about a problem with a pump, a heart pump problem, it's only cardiogenic. If they talk about vasculature problem, or pipes, or whatever, arteries, veins, distributive shock, dilation. The four that I want you to know about: anaphylactic, septic, neurogenic, and psychogenic. Hypovolemic shock, most common form of shock. All shock is hypovolemic shock until proven otherwise, or unless you know that it's not, okay? Hemorrhagic shock, metabolic shock, okay? These are the shocks. This is what you need to know. The signs and symptoms we're going to go through in a minute for the different types of shock. What I want to say is something else. What I want to say is like this. If you find a 18-year-old on a baseball field laying there, let's say unresponsive, whatever it is, and you think they're in one of the types of shock, are you thinking septic shock?
Oh, no.
No. Which one is the most likely from these shocks?
Psychogenic?
Psychogenic?
Hypovolemic.
Again,
No.
You don't know
you
anything.
don't know anything.
But which one should be a possibility in your mind?
Metabolic.
Neurogenic?
Neurogenic, right? Is it possible that he got clocked over the head with a baseball bat.
Maybe he's allergic to pollen.
But you see something? Do you see something?
No, no, not yet. You're walking up. Is septic shock one of the things you think is going to be occurring?
No,
Right. But when you walk into the nursing home, okay, and you see a patient that is laying there, do you right away think, okay, this is neurogenic shock?
No.
No. The most likely cause of this shock is going to be sepsis, right? So again, sometimes you just got to think of your surroundings, you got to think what you see, and you got to take it all into account. Now, it doesn't mean that you must not get blindsided or tunnel vision. Tunnel vision is one of the worst things that can happen in EMS, the EMTs. Okay? Because tunnel vision sometimes can be from left field, we can be so far wrong, and yeah, it could be that this kid has been brewing an infection for the last 2 months. He's not living at home, he's living in a dormitory or something, he hasn't taken care of it, all of a sudden it got the better of him, boom. Maybe he is septic, I don't know. But you have to always have what I call a doorknob diagnosis. You have to always think, when you walk in, what do I see? What do I smell? What am I thinking? All right? You have to have something that you're going in with. Now, you have to also be able to make a 180 turn on that. That's all part of it. Okay? Just keep that in mind.
but aren't the symptoms of shock and, let's say, internal bleeding very similar?
Well, we didn't
Past
really
that.
get to the symptoms.
What type of shock is it called when you if you pass it from low blood pressure?
Any of them.
So again,
Could be any of these. We'll talk about it. Okay? These are just pictures showing you what I spoke about, okay? So this is the heart with a problem, the pump.
You done with this one? Back to the light.
Yeah, but you're not done with this book. You need to learn that page, okay? This is where there's blood leaking from the system, so there's low, right, fluid. And this one is with, see the swollen blood vessels, dilation, okay? All right.
Dumb
Here.
question. Is it dilation or dilation? Is it D-I-L or D-I-A? Same word as diastole? Same word?
Dilate.
He doesn't know how to spell it.
Dilate.
D-I-A.
Dilate, not dilate.
It means the same thing as
Dilate is dilate.
Alright, right, smart.
Okay, this is just wording based on what we spoke about. Okay, neurogenic, anaphylactic, septic, psychogenic. Okay, so just some words to help you, whatever, we don't need to go into it again. All right, this I changed this slide from the way you have it, but it's the same stuff. I just changed the order around. Okay. One thing in medicine that we're going to talk about a lot is mental status. Okay? Mental status is something that you cannot necessarily gauge on your patient because you don't know the patient. Okay? Mental status is something that you will normally be told by a loved one, a family member, or a friend, or somebody that's around there. They're not acting right. That's the most common way that people say it. They're just not acting themselves. They're not acting right. When you hear that, you have to translate that into AMS. Okay, the acronym AMS, Altered Mental Status. When we use this a lot, you got to know this Rosh Hashanah AMS.
When you hear what?
Someone's not acting right.
Someone's not acting right. Okay? AMS. We're going to talk about AMS in greater detail later on when we do medicine. So for now, all you need to understand is that somebody tells you this is not the way they usually act. Okay? Now, sometimes you can tell that they're AMS, meaning you come in and you're like, buddy, how you doing? What's going on? Talk to me. And they're like, roses are red, you know, or they just start saying crazy stuff. They may be AMS. You can figure that out on your own. However, they may be crazy from Crazy Town. So you don't always know. So usually somebody will tell you they're not acting right, then okay, AMS. So that's one of the things that happens early on when you're looking at hypoperfusion. Another thing, just again to touch on AMS really quickly, is it's probably the best predictor of general how is your patient doing. Okay? It's one of the things that you can find out really quickly, and it's a very good indicator of what is the story with your patient. Okay? So if I come in and hi, how you doing, what's your name? And he answers me, what's going on, how we doing, where are we, all this, right? I see he's with the program. But if he's not answering me normal, or he's not answering me at all, so right away, I'm able to form an opinion that this patient, okay, maybe he's AMS. Now I gotta figure out why. Lots of medical problems cause patients to be AMS. The most common are the diabetic emergencies, which we'll do later on in the course, okay? However, shock also causes AMS. AMS could be on a level of confusion. AMS could be...
Dizzy?
No, just dizzy won't be AMS, because they'd be able to answer some basic questions. Anything from being confused to being in a coma is AMS. Anything in between. Okay? I don't want to get into it tonight. We will. Okay? Tachycardia. Tachycardia. We've spoken about these words. Tachy means fast. Brady means slow. It's in your books. You have notes. You have my thing on this, right? Tachy and Brady. So tachycardia is something that you will see very early on in a patient who is AMS. We'll talk about why in a minute. We'll talk. Tachypnea. What does that mean?
Fast breathing.
Fast breathing. Okay, we'll talk about the reasons behind it. Pale, cool, and clammy skin. All right? These are all things that happen quickly, and you will see pretty early on. They're going to ask you for early and late signs. Early signs of hypoperfusion and late signs of hypoperfusion. These four, 1, 2, 3, 4, are all what I would consider the early signs of hypoperfusion. They are going to test you on this.
Say that one more time. Say that one more time.
There are early signs of hypoperfusion and late signs. Okay? The most common early signs are the top 4 in the list.
It's different in our book.
Yes.
This is true.
Nausea, thirst, sometimes capillary refill. It's only in children. We'll talk about it when we do pediatrics.
What's clammy? What's clammy skin?
Wet.
Okay. Skin is supposed to be not wet and not dry. It's supposed to be like the way you feel it. Clammy is where there's a moisture, like a sweat on the skin, but it's not 100 degrees in the month of July. Okay? So it's like a sweating, but not to do with being in a hot temperature. Okay? The body is putting it out there. We'll talk about the reasons soon. Orthostatic changes, I'll get to. Decreased blood pressure. Okay, so this you want to highlight and underline, okay, because this is an answer to a test question that they always, and some of you really got to know, even for real life, okay? You got to know the early signs, you got to know the late signs. Decreased blood pressure, if you come to a patient and they're in one of the shocks for whatever, doesn't matter which, and you have a pressure of 70 over palp, right? We're late. We're in bad state, okay? So you can know where we're up to. We're going to talk about that in a minute. Early signs will be AMS, tachycardia, cold pale diaphoretic skin.
Oh, it's different over here.
Right, it's a different order.
Yeah. This is a better
So the
order.
early signs is when it goes quick and then it shoots down? Is
Yes.
that what it is?
Okay, if you like, yes.
Because that's what the decrease.
We'll talk about it. Some specific,
Tachycardia,
yeah, those are general,
AMS, nausea, tachycardia, you had one more.
Tachypnea.
Not nausea.
Tachypnea and pale, cool, clammy skin.
Cool, clammy skin, and AMS.
Nausea
Those are-
versus the late sign?
they're rare, more rare, okay?
What about delayed capillary stuff?
That's only we do in children. We don't do that. In New York State, it's not done on adults anymore, so we'll talk about that when we do pediatrics. Orthostatic blood pressure, let me just tell you what that is real quickly.
Lips?
Orthostatic blood pressure changes. It's a really good thing to do. The problem is that New York State, New York City really took it out of your protocols. But it's a good thing to do. I hold of it and I make my EMTs do it sometimes. Orthostatic changes means that you take a blood pressure and a heart rate with the patient laying down. Then you take a blood pressure and a heart rate with the patient preferably standing. But if you can't do that, then you do it with them sitting. Okay? So you can do sitting to standing, laying to standing. Okay?
Could you lay into Fowler's?
Yeah, laying could be semi-Fowlers. That could be okay. Yeah.
Just change position.
Okay? But basically, you want them standing really for the second set. Okay? And orthostatic changes will be a change of greater than 10 in the blood pressure or the heart rate when they're standing. So the blood pressure would decrease by 10, the heart rate would increase by 10. That would be an orthostatic change.
That's a late.
Okay? Yeah, anything with the blood pressure is considered a late change. Okay?
That would confirm that you're in the late stages of a shock.
No, just having a low, if you have a low blood pressure when you get there, you don't do orthostatic changes. Okay? Orthostatic changes are only done on people that are doing well, looking good, but you're just not sure, you just want to double check their blood pressures, okay, in both positions. If they're really doing bad, you don't need orthostatic changes.
So shouldn't that be a part of an initial?
But it's not always done, like I say, it's just there, it's something that you can do, alright? It's not always done. Let's try to move on, still a lot to do. Anaphylaxis we're going to talk about in a separate lecture. Cardiogenic we're going to talk about when we do MI. Metabolic, signs of dehydration. Okay, so they may have a white tongue, may talk about vomiting, nausea, vomiting, diarrhea for a long period of time. Sepsis, long time infection. Okay,
What's that, inadequate tissue trigger?
that's when you pull up on the skin and it doesn't go back. Okay, the way it's supposed
That
to.
happens a lot with old people.
Yeah.
I'm saying even in a regular state.
All right, let's do this. This is key. Okay, so there are two states of shock that you will typically find your patients in, one or the other. All right. Again, this is no matter what type of shock it is. They could either be in compensated shock or decompensated shock. Now you hope that you find your patients all in compensated shock if they have to be in shock, right? What does it mean? Very simple. Compensated shock means that the body is able to maintain the blood pressure. The body is able to do stuff on its own to prevent them from losing their blood pressure and completely going out on you, all right? What are the things that the body can do? Well, the first thing it does is raises the heart rate, makes them go tachycardic. So, typically, if you have a patient who may be in shock, the brain sees that there is blood pouring out. The brain understands that, okay? So it does a few things. First of all, tells the heart, work harder, pump faster. Why? Because if the heart pumps faster, the blood pressure should go up. Okay? Also, it will create and send more platelets to the bleeding area. So the brain only sees it from its own standpoint. The brain understands that we gotta do stuff. It's gonna make you breathe faster, tachypnea. It's gonna make you blow off more CO2. Again, the same idea. Blowing off CO2 is going to hopefully bring up the blood pressure. Now, the skin. Remember, let me just finish this. Remember earlier on I mentioned that the brain, the heart, they are like the rulers of the body. They're gonna get their portion of oxygen. So the brain pretty much says to the skin, I'm gonna take your blood supply and your oxygen because I need it more than you. Okay? So the skin says, okay, I guess I don't really have a choice. Okay? Skin says, but if you don't give me mine, I'm not gonna do my job. I'm a union. Okay? So I don't get paid, I don't work. So the brain's okay with that because it hasn't got a choice. The brain's gotta pull from somewhere. Okay? So why does the skin turn pale? Why do people say, oh, white like a ghost? Okay, why do people go white? Because the brain has pulled the blood supply from the least vital organ, meaning the brain, the skin, and has shunted all that blood and oxygen to itself, to the brain. Okay?
So when you're saying compensated, it means that the brain has compensated. And
The body, yes.
And therefore the body is doing all
The
this.
body is doing all this on its own.
Because the brain has compensated
Yeah.
for what is happening.
I mean, yeah, but let's just say the body is compensating. The patient is
At this
compensating.
stage, the body's able to deal with whatever.
They're dealing with the problem.
Right.
Okay? Trying to.
Right.
Okay? Now, the next stage is called decompensated shock. This is where the body now gives up. Can't. It's tried. It's tried to compensate for the loss, for the vasodilation, for the whatever it may be. And now it says, I can't. I'm done. Finished. Well, how do we know when we get to that stage? So it's very simple. We picked a number, 90. 90 systolic. If the patient has a blood pressure of less than 90 systolic, that's your cutoff. That means that now they've got into decompensated shock. Okay? Again, doesn't matter which one or how they got it or what, it doesn't matter. These are just general terms. These are the two types of patients really that you're gonna see. Okay? Hopefully you get there quick enough. They'll be in compensated shock. The body will still be fighting to maintain a blood pressure. All right? Once the blood pressure has dropped below 90 systolic, Houston, we have a problem.
Are they conscious, responsive by either of these?
By compensated, absolutely. But they may be AMS.
Right.
By decompensated, they may still be conscious. Yes, absolutely. They could still be conscious. Okay? Irreversible shock's not really something we deal with in EMS. I mean, it's pretty much dead, you know, as far as we're concerned. We don't really get into it. Okay?
What's the blood, what's the systolic on irreversible?
Well, they may not have one.
So that's everything, by decompensated, everything becomes, what, Brady? Brady?
Brady, yeah, things will start to Brady down, yes. Yes. Okay? All right, so treatment for hypoperfusion. How can we treat? So, first thing is we need to maintain the airway. We need to position the patient, needs to be at least supine. We need to give oxygen. Why do you think we want to give oxygen? Based on what we learned tonight.
Because it's giving out to all the other areas, it's
Pulling it,
taking
you
away
wanna-
from many areas except.
You want to
Right.
level it out.
Right, oxygen isn't getting delivered everywhere that it needs to go. We're gonna control bleeding, we're gonna splint, we're gonna maintain body temperature. So, one of the key functions of the skin is thermodynamics, body temperature regulation. what did I tell you happens in shock? Skin stops working. So a patient may start to get very cold even in a very warm situation, okay? So remember this, one of the treatments for shock is maintaining body temperature, blankets, putting the heat on in the back of your truck. This is simple stuff, but it's so important, okay? Elevate the legs, Trendelenburg, there it is, for those of you that didn't know how to spell it. And apply mask pants.
Is this a specific order?
No,
Is there one that is more important than the other?
Maintain airway.
well, you gotta keep the patient alive, you gotta give oxygen,
Better control bleeding.
and you gotta control the body temperature, you gotta elevate, yeah, whatever. all of it. Now, let's talk about mask pants.
End zone.
Picture ready? Okay, good.
Makeup.
Action.
Okay, so we're gonna talk about mask pants. Mask pants are very interesting, okay? Mask pants stand for Military Anti-Shock Trouser. They're also known as Pneumatic Anti-Shock Garments. What do they have in common? Anti-shock. They're the same thing, just two different names, okay? So, these were developed, I don't know, in the 60s.
P?
Trousers?
T trousers, yeah. These were developed by the military, that's why they're called mask pants. Military anti-shock trouser.
And EU.
And they have been banned in New York City. Okay? So we're gonna learn a new word now, it's really important. Okay, big word. Contraindicated. Contraindicated. Okay? We're gonna talk about mask pants more. I'm gonna show you, I'm gonna speak about them.
Indicator?
Yeah, they are contraindicated in New York City. Now, there's gonna be a whole bunch of mask pants things you gotta know. Because remember, this is a New York State class, and they are still available to be used. If you go 100 feet down the road there, you're probably not in New York City anymore, right?
That way.
Whichever, yeah. You know what I mean, right? So we're right here, we're right on the border. So if you're in there, well, if you're Hatzalah, it doesn't matter, because we run under New York City protocols. But if you go join, you know, what's it called, Valley something, Valley Stream or something, right over there, they would be fair game, okay? And this is a New York State course, so you gotta learn New York State protocol, okay? All right. Oh, best thing is to go to NYU on a matzah Shabbos.
What?
Oh, they have great malava malka. All right.
Leftover chunk.
No, fresh bagels and spreads. Oh,
They actually have a great Peter Cola room.
Oh, you're here.
the best.
We're by NYU?
Hence why I took the lava.
Where is that, down by Atlantic?
No, in the city.
No, in the city.
In the city.
There's
There's a hospital right next to the NYU Liberal Arts College.
I like Georgia.
What's that called?
I like Jan.
In downtown Brooklyn,
Yeah, it's all the way down.
Oh, that's just.
Cobble Hill. It's NYU. It's a Brooklyn
Branch.
branch of NYU. It's not a hospital. It's just an ER.
No lava malka.
No lava.
No malava malka.
They have great vending machines though.
That will be.
All right, moving on.
Okay, talk about the mask.
It's a 5.
What's this contra in whatever?
Contradicting.
You got to be able to say the word.
Contraindicated means it's not indicated.
The word means in medicine that really I would like to use such and such a treatment or medication or whatever. However, because of something else, I can't.
Contrary.
That's contraindicated You understand? Again, really I want to use mask pants on this patient, but because I'm in New York City,
Can't use.
can't use them. Okay, we're going to learn a lot of contraindications for the mask pants. Okay? Alright, let's just finish up this stuff. Anaphylaxis I really don't want to go into. Cardiogenic. Let me talk a quick word on cardiogenic. One of the symptoms of cardiogenic shock, guys listen, write it down. One of the symptoms of cardiogenic shock is fluid in the lungs. Fluid in the lungs. Anybody have a half full? Give me the Snapple bottle. Yeah, this will work. Half full. Okay. Here's a patient's lungs. There's fluid in the lungs. You see? Can the patient breathe?
Yeah.
Yes. Right? Because? Still space, right? Now we lay the patient down. Can the patient breathe?
No.
No. Did we kill the patient?
Yeah.
Pretty much.
Yes. Right? So now you understand cardiogenic shock. They've got to be,
Standing.
Standing up.
right, but you can't transport them standing.
Sitting.
Sitting. Sitting. Okay? Fowlers. Or sitting. Okay? That's really that. So fluid in the lungs, do not lay the patient down. Psychogenic shock, self-correcting, we spoke about that already. Here we go. Mask pants. As of 2002, mask pants were removed from every ambulance in New York City. You will not find them. I will have a pair here to show them to you probably at some point. But New York State, you know, if you go decide to work in Ithaca, New York, or somewhere other, you know, exotic location, you may see mask pants. So you gotta know what they are.
Why did they,
Why they got rid of them? Because it takes longer to put them on than the good that they do. Okay? But if you've got a 45-minute hour transport and your patient's in shock and they're gonna die, then they really are great. Alright. So indications. Indications means when should I use them? The opposite of contraindication. Okay? Indication, when should I do something? Contraindication, we're going to use this word a lot. Listen, you guys are learning medicine. Alright? So, indication, contraindication. We use these words. These are like common words, like table, chair, contraindication. These are just normal things that we say. This is how we speak, alright? Don't worry, don't be scared. It's a big word. It's okay. You don't have to spell it. No.
Just scribble it.
I don't understand, you're supposed to put this on the patient?
Wait, we're gonna tell you.
Oh.
Yeah, hold on. Hold the horses. 2002, out of New York City, every ambulance. You will not see one on an ambulance, okay? Okay, well, we'll get to it. Hold on. All right. So, when is it indicated? When should I put the mask pants on the patient? All right? So there's one really easy one, and that is that the patient has a systolic blood pressure of less than 50. Okay? Right? So that patient's doing pretty bad, right? Less than 50. So you come there, systolic blood pressure less than 50, they're still alive, put on the mask pants. As long as we don't hit any contraindications. Why you look perplexed?
you said under 90 already is
The
guy's pretty much.
right, but
No,
this
under 50, he's pretty much 1 foot out the door.
close to it. Correct? Okay, that's why we're using it. Or not. Right? Now, the other one is if the patient has a hip fracture. Where does it say this?
Pelvic fracture.
Yeah, same thing. Where does it say this? Here you go. Patient has a pelvic fracture and a systolic blood pressure of less than 90. So you're ruling out a pelvic fracture, systolic pressure has dropped to less than 90, you would be indicated to use mask pants. These are the only two indications. Alright, as far as really you're concerned.
Now, the reason why by pelvic fracture it goes up to 90 is because of the blood, because of the
Internal bleeding that you have no way of controlling or dealing with. Alright?
But
Alright,
it is
now,
something-
contraindications. It's gonna get difficult, but I'm pretty sure each and every one of you can hold with me, right, and get this. There are two types of contraindications to using the mask pants. Two different types, okay? There are complete and absolute indications not to use it, contraindications. Absolute, that means living in New York City is an absolute contraindication. Doesn't matter, nobody cares, don't explain it to me, you can't use it. So those are absolute. And then there are relative contraindications. Relative means you can use some of it, but not the rest of it. It's three separate parts, I'll talk about it in a minute. What are the absolute ones? So you don't need all of these. So, you can add living in New York City at the bottom,
Well, it's kind of there, less than 30-minute transport time.
okay? There's two. This one,
Which one?
pulmonary edema, which you can change as water in the lung, is a definite don't use it. So fluid in the lungs, water in the lungs. And this one, penetrating chest trauma.
Is it chest pains?
No, penetrating chest trauma is someone stabbed in the chest. Okay?
What's unilateral, bilateral?
Bilateral, both sides. Unilateral, one side. But why? Yeah, don't worry about it. Water, again, two things. Water in the lung, penetrating chest trauma. Living in New York City. Okay?
Very common.
These are the three you need to know. Absolute, absolute. Which I don't really drink because it's not very good. Grey Goose is much better. However, absolutely don't use mask pants. Okay? Completely absolute contraindications. Relative. Relative, we use the acronym PI. PI, as in apple. Or other pie. Okay? And that stands for P for pregnancy. Now, if you have a pregnant patient with a pelvic fracture and a systolic less than 90, right? Right, would be indicated to use it. I didn't explain to you how it works yet, but the mask pants come in three parts. Abdominal, left leg, and right leg. Which part are you not using on the pregnant woman? The abdominal part. Simple. Impaled object. Let's say they've got an impaled object in their right leg. They've got a knife, dagger. Right? What would you use?
Not the right leg.
Left leg in the abdominal. Evisceration. Have we used that word yet?
Disgusting.
Fantastic. Evisceration is where the kishkas are hanging out. The intestine, the abdominal wall has been cut and the intestines are protruding. We call that evisceration.
Some great pictures on page.
Okay? Evisceration. Which part wouldn't you use?
Abdominal.
Abdominal part, right? But you could use the other two.
Do those work like the DVT sleeves?
No, let me explain. Let me talk more, and you know, I have a little video I'd like to show if we can, but whatever.
Evisceration video.
You have a evisceration video?
What?
Evisceration video?
No. I can get one for you.
No.
Alright.
No, it's a mass pants video. So how to apply it? I'll show you on a skill night. Here, I'll just show you really quickly. These are the different pieces of the mask pants. So it's one garment that lays out flat. This is the abdominal portion. It's all Velcroed. You see the Velcro? Right? It all gets Velcroed together. They're putting together here the leg. The abdomen is on, leg, right? And then there's a foot pump. Usually, the ones I have had were foot pump. Some have a hydraulic pump if you have a lot of money. And you pump it up, okay? And basically what it does is it sends all the blood from the legs and the abdomen up into the chest the heart, the lungs, the brain, right? And that's really what it does. It sort of forms a great big tourniquet in a way, and just shoves all the blood, forces all the blood up into the upper body. Yeah.
New York City, you said, does not use it. What do they do in lieu of this now?
They get in the hospital much quicker.
We're in the hospital in less than 7 minutes, so we don't need it.
And it looks like it takes 15 minutes to get that thing on.
It could take time to get it on. No, 15, but it could take time.
Have you ever worn one? Is it like?
I'll show it to you. You can wear one if you want. I'll,
Pictures of
Helps with the hemorrhage.
You walk around.
It's great. You don't have to have a
How
belt.
tight do you make it?
okay, good question.
The real skinny.
I'll tell you. Just hold on. I want to keep moving. I'll get back to it. Here is some slides on the different shocks. I have covered everything that you need to know on these already, okay? So remember the CNS is the brain and the spinal cord, remember that, right? Hypovolemic shock, we've spoken about this. Septic shock. I don't really talk about respiratory insufficiency, so don't worry about it, okay? You don't need to worry about it. Anaphylactic shock, we're gonna do a lot, on that. Psychogenic shock. Okay, here are ways how to deal with shock. Cover patient with a blanket, right? Remember that. Control external bleeding, splint, PSAG, vitals.
Oh.
Can we get a pause? So, based on everything we learned, we're going to move away a little bit from shock and bleeding per se. We're going to talk about soft tissue injuries, what they are, how to recognize them, and what to do with them. So, of course, I always start with a quick review on the anatomy of what we're dealing with, right? So, when there's soft tissue injuries, that usually means that the skin was cut. So just quickly again, there are 3 layers of the skin. You are responsible to know the 3 layers, the names, the order, and pretty much some basic things, what they do, okay? So, top layer of skin is the epidermis, middle layer is the dermis, and the lowest layer is the subcu, I taught you last time, subcutaneous layer of skin. Okay, we're going to talk about the difference between closed and open injuries. Okay? These are examples of closed injuries. So, words we need to know. Word number 1 is a contusion. A contusion.
The bruise?
That is a bruise. Right, very good. So, now, in grown-up speak, we're going to say contusion. There is another word for it, it's used less often, and that is ecchymosis.
Thankfully.
With 2 C's.
2 C's. Very good. Ecchymosis. All right, it's used less often. More often we use the word contusion, and these are bruises. What is a bruise? It's a small capillary leak under the skin, close to the skin. All right? Hematoma. You ever saw the boxer get a good right hook and he's got that big bump? Okay, that big bump. That's a hematoma. Hema, guess what? We're using that word again.
Blood.
Blood. Hematoma, collection of blood. It may not show through discolored like a contusion. It may look like that, okay? But it's deeper than the layers of the skin, and it's a collection of blood, a hematoma. Know these words: contusion, bruise, hematoma, large collection of blood.
So it's raised, the hematoma?
It will stick out, yes.
Oh, mom?
Yeah.
So when you bump, your kid bumps his head.
Yes, and you get that bump, that's a hematoma. But you may not see any discoloration of the skin because it's a larger vessel and it is lower, okay? It's not just the capillaries at the top.
So why do they say to push the, is that anything?
Here you go, Sean.
We're not gonna get that.
No. Treatment of closed injuries, well, there's not much really to do. So, of course, ABCs will always be first. expose the area,
BSI.
treat for hypoperfusion, right? If they're going into shock for whatever reason, and you may need to stabilize it. Okay. Our main focus is going to be on open injuries, okay? These are 5 open injuries. You need to know them. You need to know the names. I would highlight these. I would learn these names. And these are things that you'll see on a very regular basis. Number 1 is an abrasion. This is what we call a scrape. Every time a child falls and scrapes their knee or scrapes their arm or whatever it is, any type of scrape, anything that involves the outer layers of skin, we call an abrasion, and that is the medical term for it. A laceration. Laceration. This is a cut. Any type of cut in the skin is known as a laceration. Okay? It does not have to be surgically straight. It does not have to be perfect. It could be jagged. It could be, but we call it, for short, it's known as a LAC, L-A-C, short for laceration. And there may be a lot of bleeding involved with it. Again, depending on how deep it is.
It's generally deep cut.
No, it's not generally deep. Generally longer than it is deep. Okay, it's not deep.
Okay.
Okay, we have a different word for something that's deep. Avulsion. Avulsion is where skin gets ripped away, but is still hanging. Okay? So somebody may get part of their hand, the skin part may just get pulled back. An earring on a female, whatever, gets caught, and the earlobe has now been ripped away, but it's still hanging. These are avulsions.
Is there bleeding by avulsion or not?
Yes, yes, there'll be bleeding. Sure.
Severe bleeding, sometimes.
Puncture. Here's where we talk about something that's deep. A deep wound is known as a puncture. Okay? And the definition is that it's deeper than it is wide. Okay? So, gunshot wounds, stabbings, these are punctures. Impaled objects, these are punctures. They go deep. Amputation is the removal of a body part. Someone asked me about someone getting an arm cut off, right? So that we would call an amputation.
In avulsion, that the piece comes completely off.
No, it's hanging.
No, avulsion that comes completely off would be.
No,
amputation?
no. Has to be a limb to
Oh,
be
okay.
Alright, here's a picture that somewhat sums up, shows you a little bit what's going on. Okay? So here's the avulsion where the skin is peeled back, but still hanging there flat. You see that? Okay, puncture, okay, deep. An abrasion is just a boo-boo on the surface. Laceration.
Okay.
Okay? And amputation. Right? Completely removed. Crush injury, we don't really go into too much. I was by a couple of Thursday nights ago, I was at the state exam with some of my students, and there was a whole group of Heimische students. They weren't from my class, and they all came in and they sat down, and somebody realized who I was or whatever, and so they had a big question for me. This is what was worrying them right before their state exam. What was worrying them was if a laceration had to be straight cut or if it could be
So it's
jagged.
clearly that it makes a difference.
Right, it really makes no difference. A straight, perfectly straight cut is known as an incision, okay? It really makes no difference, but by no means is it a must. They thought it had to be a straight, perfect cut, like a surgical cut. No, it could be, but it doesn't have to be, okay, could go either way, and that's what I told
If a
them.
piece of skin on an avulsion is
The difference
removed,
is
does it
in the-
become a
is in the-
laceration?
No, does it become a laceration?
It's not hanging, it's cut off.
Or the
When
brain.
it heals,
No.
with the scar
It
tissue.
may be
Right.
considered
There's a different-
laceration,
There's a different name for the
It
scar.
may be,
scar
yes.
tissue.
yeah.
Okay. This is only the scar tissue.
All cuts are pretty much known as as lacerations, for the
Laceration doesn't
simple.
mean skinny, by definition. An avulsion sounds like,
Again, the definition of avulsion is that it's hanging. There's a flap hanging. Alright? Alright, treatment of these injuries are pretty much going to be the same as we saw earlier when we spoke about the treatment for bleeding. Okay, same thing. BSI, ABCs, control the bleeding, right? Which ones of these we're using now? Okay, we're not using elevation or pressure points, you can cut these out for now.
What do you mean not?
We're not doing them anymore.
That's it, then?
Okay? Here, very important. Do not remove impaled objects unless they block the airway. And let me say that again, and you should be highlighting that. Do not remove impaled objects unless they block the airway. So if somebody has an impaled object in their knee, is that blocking the airway? Pretty much not. Where would it block the airway?
Chest,
The cheek?
the neck.
The neck?
Chest. Chest.
The chest? Really?
What if it's the
Cheek.
brain?
The airway?
Why would the cheek?
This is not gonna stop you from bleeding.
Whoa, 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 whoa. Listen to the definition. Do not remove an impaled object unless it's blocking the airway. What is your airway? The airway is the ability to get
Here.
air from out here
Inside.
inside here. That's the airway. Okay, just till here. All right? So yeah, the cheek, the neck, these are going to block the airway.
Why the
Right.
cheek?
how does she block the airway?
Well, it
I
depends
guess
what part
it's
of
big
it.
enough.
No, I'm saying, I got a fork stuck in my cheek much years ago, and
Wow.
I pulled it out, so I went to the doctor. Doctor said he shouldn't have,
Okay.
you're saying,
Again, I didn't give you anatomy of where you can remove it and where you can't. I gave you a general rule.
if it's blocked.
If it blocks the airway. So again, they're going to give you a test question with an impaled object in the cheek or in the neck, but if it's not, doesn't tell you that it's blocking the airway, doesn't count.
Did you make up a better story?
So the lungs is not the
I'm
airway.
saying, did you make up a better?
As long as the question or the patient tells you that, you see it's not blocking the airway.
Yeah, but the truth
So the knee is no good, and the
I have a
kidney,
mark.
I thought it was a question on the knee, and then you were gonna say the kidney, but that was just. Sorry.
Now, okay.
Is the kid's knee what?
Do not remove the object. Only if the airway is blocked. Control bleeding around the base of the object. We're going to show you how to do that. Do you want to shut the lights for a second just to
Wow,
see
you wanna
this?
see those nice, beautiful
Yeah,
pictures?
a little clearer.
Oh, the picture's got some more, the book.
Here you go.
Oh. leave it.
Okay, so this is
Clear.
rebar right through the hand. Hold on, we got something.
That's not a lock airway.
No,
Right.
you should know, when I was about 7, 8 years old, my brother, we were playing by a fence like this, he fell off a second floor porch, landed straight on the scrotum on there, and I wasn't tall enough, I was with a guy, a boy, who was 8, picked him up, pulled him off, and he was carried him down the block, he was just bleeding out of his pants. Baruch Hashem, he has kids, Baruch Hashem, but
Oh my
that
You
was,
weren't supposed to take it.
so we should have just left him on there.
Yeah.
Which knee?
Good stuff. I thought I was, the only thing I could do was bring him to
Get
his
him off.
parents.
All right.
Like, he's-
So,
Which knee?
Wow, that's insane.
so if this didn't kill him, it certainly wrecked him. Anyway, you can put the lights back on.
You practice that one.
All right. So, in situations like this, In situations like this, we would certainly call for FDNY or ESU, and they would cut down as much fence as necessary, and we'd probably transport him prone, because we wouldn't want to put him supine, right?
No, but in a situation like this, leaving it like that,
Yeah.
you know, the thing moves around a little bit.
No, you're gonna stabilize it so it doesn't move around.
Yeah.
Yeah, but if it's like the way he's describing
I
it,
was probably turning around and go home.
I have a picture, I have to show you, I have a picture from the trauma team in South Africa of a piece of metal piping that they removed from a patient. I'll try to show it to you. You wouldn't believe it. You wouldn't believe that this patient walked out of the hospital. Okay? So, it does happen.
Was it an elephant tusk?
So you're saying
It was
it
a firefight.
happens sometimes?
I saw it, I think I saw the
main
video.
line.
Oh, wow.
Yeah, one of those.
That's crazy, Ellie. Which brother?
But it's rare.
Ellie,
Extremely.
Rare.
Yes. Okay.
eye injury.
Rear. That was rear.
Extremely.
All right. Eye injuries, important, right? Okay, it's important. This is stuff you see day to day. You see this in schools. You see this whatever. Okay. Number one, do not remove the object. Right? Is the eye blocking the airway? No, usually not. Very good. We're going to teach you how to do this. We're going to teach you how to stabilize it. You cover both eyes. Okay? There's something special about the eyes called sympathetic movement. When one eye gets affected or moves, the other eye moves also. So if you cover this eye and this eye moves, that eye is moving just as well. Okay? So you cover both eyes. You stabilize the penetrating object, whatever it is, and we'll show you how to do that. Dirt. This is important. Underline the, whatever. Highlight this. We flush eyes in a medial lateral direction. Medial lateral, right? Which means
Middle to outside.
middle to outside. Very good. All right, epistaxis.
Wow, that sounds better than nosebleed.
That's what we call it. And as when I taught the medics in Williamsburg, they couldn't say this word. I said, just say epis in Texas. They were good with it. All right? So epistaxis, I really did. You'll remember the word now, right? Okay? So, we spoke about it a little earlier. It does take a long time. No matter what your grandmother told you, do not tilt the head back. Okay? Head is forward. Pinch across the bridge of the nose. And you can use ice packs. I've not really had much success personally with ice packs. People say it's good. You're gonna get all the advice, what to do, what someone's grandmother told them to do, and listen. You can put an ice pack on top of the nose. Maybe it'll help. Maybe it won't. What helps is sitting them forward, pinching across the bridge of the nose, put something underneath, and it does take 20 minutes plus. Okay? So be prepared for that.
Whoa.
All right? Again, if this child is not having any difficulty breathing and this impaled object is not blocking the airway, then leave it in.
He's totally chill.
Okay? He does look
Yeah, he
pretty
doesn't
chill.
look, yeah, he doesn't look happy about that.
Right.
Oh, he's lucky
It's
outside.
like you did what?
Okay?
Should've seen the other guy.
So the
All right,
cheek is
neck
the only time you'll
wounds.
remove it?
What?
Only if it's blocked the airway.
Only if it blocks the
For
airway.
example,
Neck wounds. Okay. I'm going to start with a definition. Okay? And then we'll get to it. So this word we're going to use a lot. Occlusive dressing. Highlight it. Learn it. Learn the word. I'm going to start with a definition. Occlusive dressing. Okay? The word occlusive means airtight. Airtight. All of our bandages on an ambulance are not occlusive, okay? All our bandages allow air to pass through them, and that's part of what we want for the healing process. There are 3 specific times that we're going to use an occlusive dressing. You must know this word. You must be able to say it. You do not need to be able to spell it, but you do need to know the word. Occlusive dressing. This is the first time I'm going to speak about it. We're going to be 2 more times. I'm not sure if it's tonight or whenever it is, but you're going to see it. If somebody gets a large open neck wound, okay, whether it's impaled, it's not impaled, whatever it is, it's blocking the airway, there's going to be a problem, right? It's coming out. Now we have this huge gash to the neck. We are concerned that if there are vessels, vasculature that is open, air can rush in and go up and cause an air embolus, like a bubble of air is going to affect the blood supply going to the brain. And this would be bad. Okay? So, this is how we deal with it. We use an occlusive dressing. So right away, as soon as you get there, you see the thing, stop the bleeding, put on your regular, you cannot put a tourniquet around the neck. Right? As much as you dislike the patient. You can't do it. Okay? So, you can put direct pressure on one side, okay? And you can take that down as best you can, but we do need to get an occlusive dressing on that. Occlusive means, again, airtight. What do you have? Now, most ambulance companies do not carry pre-packaged occlusive dressings. They are made, but they're used so infrequently and they're so expensive that most ambulance companies do not carry them.
Okay.
Occlusive dressing means anything that's airtight, which really is plastic. All of your equipment, all of your disposable equipment comes wrapped in plastic, okay? So you just cut open a piece of equipment in plastic, cut the size that you need, and tape it all around. That's an occlusive dressing. Plastic is airtight.
Blood is pouring out.
What?
In the meantime, blood is pouring
Well, in the meantime, you've dealt with the blood,
Well, not necessarily.
and you don't know how much blood is pouring out, but you're going to deal with the blood first, and you may be putting the occlusive dressing on top of your regular non-occlusive dressing.
If it's plastic, what makes it so expensive?
No, the pre-packaged medical sterile ones that.
Are you not concerned about the blood going back into the
No,
the airflow?
no,
Why not?
What do you think?
it just
is
won't.
plastic?
Blood pouring out that way.
You think it's,
Can't choke
you're,
on the blood?
obviously there's no,
No, we're worried about air getting into the vasculature and causing an air embolism.
That's why they tap a needle before they inject you.
So you use the plastic from like a sterile gauze pad? Or plastic?
Well,
like-
gauze
like-
doesn't come in
No,
plastic,
paper.
but your oxygen equipment and your masks and things
Got it,
like that,
got it,
yes.
got it.
The inside of all that is all sterile, yes. Okay. The sterile gauze comes in paper,
Papers, you don't use.
but that's
paper.
not
Yeah,
occlusive.
right.
You said there are three times.
Right, well, we'll get to
so
it.
got the one large open.
Okay, this is a large topic, very, very important topic.
Chest injuries.
This is quite complex. Anatomy of the lung, okay? So the lungs are here, what's that called, that pipe? Trachea.
Yeah.
It breaks off into 2 main bronchi, good? And then we have
Bronchial.
each lung, okay? Yeah, from the bronchi, we have bronchioles,
Alveoli.
and then the alveoli, very good. So, we have each lung. Now, here's the diaphragm at the bottom, okay? And this is our respiratory system, all right? Pretty much. Now, the lungs are surrounded by a special sac, a special protective coating, special protective covering, and they are called, it's called the pleura. You gotta know this word. pleura.
What's the plural?
Pleura. The pleura is a special protective sac that the lungs sit in.
How do you spell it?
Pleura. The pleura. Now the pleura has two layers.
Top one.
There is the outside layer and the inside layer. The inside layer is right touching the lung, and the outside layer is just a tiny, tiny amount of space away from the lung. So if you look at this lung over here, which lung is this, the left or the right?
Left.
Left, good. This is a tiny space, and that tiny space is known as the pleural space. Okay?
What's generally in there? Just air?
Just some surfactant.
Just
Nothing.
mucus?
Surfactant.
What is it, mucus?
Nope.
What is that, what's the fact?
Special chemical in the body that prevents it from rubbing against each other, like lubricant. Okay? So here you see the two layers. Here you see the dark black line here, the inside, the visceral pleura. And on the outside over here, you see the parietal pleura. All right, these are the names. The visceral pleura is on the inside, and the parietal pleura is on the outside.
Parietal? E-O?
No, P-A-R. Parietal. Parietal. Okay? Now, if somebody gets stabbed in the chest, and the knife goes through the chest wall and makes a hole in the pleura. Now there's an open space from outside all the way into, well, not into the lung, because the lung itself, into the pleural space. Okay? Air will rush in.
Negative pressure.
Right? Very good. Why will air rush in? Because there's more pressure outside here than inside here. So air is going to rush in. Air is still coming in and out through the trachea, the normal method. But air is going to rush in through here at a much greater rate than the way normal breathing happens, right? There's no in and out over here, there's nothing. Air's just flying in. This is known as a sucking chest wound. This is known as a sucking chest wound, and in medicine we call it a pneumothorax. Okay? Pneumo is anything to do with the lungs. Okay? Pneumonia, right? Pneumothorax.
Sucking chest what?
Sucking chest wound. So, you understand what's happening here. It's also known as a collapsed lung. Okay? So inside you've got a collapsed lung, outside you've got a sucking chest wound. Okay? And it's called sucking because you can literally hear it pulling air into the pleural space. Okay?
That's short-lived until the air pressure balances out.
No, it keeps on happening.
Because
Doesn't
you're
stop.
breathing in and the air imbalances the pressure again.
No, it doesn't. The breathing will not balance that pressure. That's gonna keep on going.
If the hole stays open, wouldn't the pressure on the inside equalize with the pressure on the outside?
No, it's gonna take a while. Watch what's gonna happen. Hold on.
The heart, right?
all the way in.
The heart.
What?
How do you know if the hole is deep enough to be able to make that hole?
You hear it.
You'll hear it, you can hear it?
You don't feel it. Don't feel it.
And when you listen to the lungs, you're gonna hear lung sounds over here and no lung sounds over here. That's how you're gonna know. and they're gonna have difficulty breathing.
Right, that.
They're breathing, they're alive, but they're gonna have a real hard time breathing. And when you listen with your stethoscope, you're gonna hear nothing here in the lungs, because the lung is collapsed. Okay? So,
How do you treat this?
right?
It's the
You gotta know what it is.
That's right.
Seems like it's
So, this is called a pneumothorax. Okay? As this gets worse and worse, more pressure is coming in, and what's going to happen is this bad lung is going to put pressure against the heart. And it's pretty much going to squeeze the heart into the good lung. Right? Because there's room
The air
for this to
pressure is gonna
move.
be pushing it.
Okay? So, the trachea may shift, and that's called tracheal deviation. TD, tracheal deviation. You need to know this. This is something we're going to revert back to when we do our patient assessments. So you'll see the trachea move towards the good side. This is a very late finding, by the way. You don't see this on a regular basis, but the state thinks you see it every day. All right? So it's called tracheal deviation. All right? You know, you have to understand why it's happening. And the heart gets squashed up against the good lung, and at some point the heart won't have room to squeeze, to do its thing. So that would then be known as a tension pneumothorax. So the pneumothorax isn't necessarily in unto itself life-threatening. They can breathe on one lung. They need to get it fixed, but okay. But if this becomes a tension pneumothorax, they're going to die. You're going to stop breathing, they're going to die. All right? How is this treated? We'll get to in a minute. Let me talk about spontaneous pneumothorax first. A spontaneous pneumothorax is where the same thing happens, but from the inside out. All right? It happens, I would say it's rare. I've seen a few, okay? I've seen a few, and I once diagnosed one on a patient in Australia over the phone, okay? But it's still rare. This happens to very young, meaning 20s, late teens, early 20s, tall males. And for no apparent reason, with no apparent trauma, they get a pneumothorax and lung collapse.
But where is the air coming from if not through a
An open wound.
It's
oh, now without a wound. Without a
No, it's
wound.
no wound.
there's no wound.
So where's the
There's
air
no
coming
wound. They get a pleural, a cut in the pleura.
from the inside?
Yeah.
From robust
And then-
exercising.
No, it's not particularly from anything.
Bad pizza.
No, it just, I don't know, it's called a spontaneous pneumothorax. And it just happens. Most of the time they don't know why it happened. Okay? So, I just want you to know about it. That's all. There's nothing not much you can do, but if you ever see a tall, skinny male in their late teens, early 20s,
Living with your lung.
and all of a sudden they can't breathe, or they're having real difficulty breathing, and you listen to their lungs, and one side is nice, and the other side is
Quiet?
nothing, then you should be thinking spontaneous pneumothorax. That's why I mention it here.
First thing.
Okay? Now, there's two other things that may happen. The pleural space may get filled with blood instead of air. And that would then be known as a hemothorax. Hemo, right? Again, that blood. And the most common of all is where it gets filled with a mixture of blood and air. And that's known as a hemopneumothorax.
In case it wasn't.
Okay? In case the word wasn't long enough, right?
Yeah.
There you go.
I don't know topic.
We got you covered.
Silent letters right there.
There's a spelling test on the screen.
No, there isn't. There isn't. I promise you there isn't a spelling test, because otherwise I wouldn't be here. I wouldn't have passed.
It's a whole Williams rig and bar park
Right.
and everything else.
Okay? So, no, there's no spelling test. But you will have to recognize, what is it called? Sight words. These are sight words. You gotta recognize them, okay? You can't look at that and say, oh, what's that? Hemo, pneumo, no. Hemo, pneumo, rhinoceros, no. You gotta know what that is.
It's like a dinosaur name.
Yeah. Okay? Hemo, pneumothorax. These are simple day-to-day words, you know.
Yeah.
This is the most common?
Yeah, hemo, pneumo, yeah.
Hair and blood.
Yeah, because this is what you see the most.
And that comes from a puncture from a
Yeah.
wound.
Usually stabs. Sometimes bullets. Yeah.
That's actually, it's just basically outside blood coming into the lungs.
It's blood from whichever vessels got burst by the trauma, yeah.
How would you know if it's that?
You may hear gurgling at the bottom of the lung and dead no air at the top of the lung. There's ways to know, but I wouldn't worry about it. How's it treated? I don't know if we got to the treatment yet. We'll get to it soon. Let me talk to you about another problem. Here's the heart. Here's the heart. Now the heart is surrounded by, guess what? A protective coating, a protective sac, just like the lungs. What's it called that protects the lungs?
Cardiac notch. No, it's
What is it called?
Pleura.
The pleura. The pleura, you gotta learn that word, protects the lungs. The heart, which is called the myocardium, the heart is called the myocardium, and that is protected by a sac known as the pericardium. Okay? There are layers, I'm not getting into it with you, okay? So, just know, the heart is called the myocardium.
You said the myocardium was a muscle of the heart.
It is, very good.
Heart is a muscle.
That's the heart. Heart's a muscle. Very good. The heart is known as the myocardium. And the heart has a protective coating called the pericardium. Now guess where the pericardium is supposed to be?
Around the heart.
Right around the heart. Almost touching all the way around. Okay? So, what happened here is that blood has now entered into the pericardial space. That, again, that tiny space between the heart and the pericardium. And now it's filled with blood. What do you think is going to happen to the heart?
Messed up.
It's not going to be able to do its thing, to pump. Very good. This is known as pericardial tamponade.
Or PT for short?
Pericardial tamponade.
And that's, we have to know that.
Yes.
Periocardial.
Pericardial.
Not perio.
Pericardial
What
tamponade.
happens? What is this? That's what happens.
Does that mean constriction, the tamponade? Because of tampon? That's not where I was going, no.
Where are we going?
What does it mean, tamponade?
I don't know. Google it. Okay. So, what was your question?
No, so each area has its own protective sac.
Okay. Well, we've learned one for the lungs, one for the heart, we're gonna give one for the brain.
Yeah, you said last time all the organs like the liver and that stuff is.
We're gonna get to it.
There's a general sac, right?
Peritoneum.
Yeah.
That was for the abdomen. Good.
Same etymology, you're right. It's the same etymology. It means to stop bleeding, to close off the area.
So how many body parts have a sac protecting?
Well, that you're going to need to know 3. The lungs, the heart, and the brain.
We did 2 of them, right?
Yeah. There are more, but I'm gonna need you to really know these 3, okay?
The pleura, the pericardial, and a third?
The brain.
The brain itself?
Oh,
No.
the brain has one too.
What's that called?
Another 9.
Oh, no, no. What's it called? Oh.
The meninges.
Meningitis.
Alright,
Really?
so,
Meningitis is when it affects this.
so, signs and symptoms. Sucking chest wounds. Sucking chest wound. Again, air is getting pulled in to the pleural space.
Can you hear
Tracheal
this?
deviation.
Can you hear the air coming in?
Yes, you can hear it sucking in, yes. Tracheal deviation is, I told you, TD. The trachea moves to the unaffected side, the good side.
Spell that right.
Okay? And JVD. This is something you need to know. Jugular venous distension. JVD. JVD occurs, well, let's stop. JVD is seen when the jugular veins, those are the veins on the side of the neck, they are bursting out, popping out. You see them when the patient is laying in a semi-Fowler's at 45 degrees, and you see the veins popping out, okay? JVD. You can Google pictures of it, whatever. So these are signs that something is wrong. Either, typically, it would be myocardial tamponade, or hemothorax.
So is
Okay.
that JVD? You see the one?
Pneumothorax.
The veins around the brain are bursting out.
Yeah, they're bursting out. You see them popping out.
When
of
someone
the
gets
sides.
angry, like you see, like the
Yeah, but that just happens for a second
Weird,
and then it goes
right?
back down.
right.
But
This is
continuous.
That's how it looks.
Yeah.
Oh, you never met his wife.
Where? Anywhere?
No, he's on the- in
no,
the-
the jugular.
Jugular.
What is that? What are the two things that cause it? The cardial tamponade and what?
And pneumothorax. Now, decreased pulse pressure, this is an interesting one. Decreased pulse pressure. The pulse pressure is what you get when you take the systolic minus the diastolic. So let's take your average textbook patient of 120 over 80. What is the pulse pressure?
40.
Systolic minus the diastolic, 40, right? It's not hard. That wasn't hard. Again, the pulse pressure is when you compute, you calculate the systolic minus the diastolic, right? So an average textbook patient is 120 over 80, which gives you a pulse pressure of 40. What if I have a patient who has a systolic of 80 and a diastolic of 70? What is his pulse pressure? 10. What has he got?
Decreased pulse pressure.
Pericardial tamponade. It's like a giveaway.
What?
What?
What? It makes sense. Listen, if the harm is so
Constricted.
right? Constricted that it can't squeeze, so its squeeze, its systole is going to almost equal its diastole, right?
Simple.
Simple. Just keep everything simple.
Well,
We don't go
But
complicated.
isn't it possible that your textbook patient is 120 over 80 and then with a pericardial tamponade, they went to 100 over 60? So it's still their pulse pressure is still 40.
Right, but it
numbers just reduced.
wouldn't be so, it wouldn't be so
It wouldn't
wide,
have
the
the
pulse
40.
pressure. The pulse pressure will narrow if it's pericardial tamponade, okay? I always mention this, Komodo cordis. I always mention it, I don't know why. It's so rare. Let me tell you how you get this, okay? Baseball. Pitcher, batter, right? Pitch goes out, batter hits, ball smacks the pitcher right in the chest at exactly a certain part of the cardiac cycle, and he drops dead,
Happens all the time.
I heard somebody. I had a friend of mine who happened to his brother.
okay? Again, it can happen other ways, but this is
Little kid.
like, it's very rare.
Years ago.
It's called Komodo cordis. Again, it's getting hit in the chest at an exact, I'm not going into because you don't understand the cardiac cycle.
There's nothing you can
No,
do,
it's
is
the
there?
fast.
Yeah, there is. Yeah, there is. There is. There is. You can absolutely get them back.
Okay.
CPR, AD, get them back. Yeah. Okay? But they literally, they drop dead. They go into full cardiac arrest. Okay?
Like that.
It's like that. When the ball smacks him, but it has to smack him in the chest at exactly the right part of the cardiac cycle.
I was born have a good day. Is that quick process?
Is there a place by your ribs that if you hit it like around over here, that if you hit it you just stop breathing?
What is that?
I'm not sure.
It's not the part of the chest.
Ask Jack Bowers.
So,
We're seeing a
No,
word.
it happened to me once.
you were going back to.
Why are you treatment of-
Yeah, but 1 second, you were still in the middle of going to the occlusive dressing.
Yeah, I know. I'm looking for the treatment slide. Is there a treatment slide?
Treatment of chest injuries, yeah, right after this one.
Supposed to be
Okay.
right after, yeah.
There you go.
Each, 44.
Good. So, let's talk about this guy that got stabbed and the knife was removed, and now he's got this sucking chest wound, and we assume he's got a pneumothorax, okay? Oh, if you wanted the word longer, the plural of pneumothorax is pneumothoraces.
Oh, perfect.
Right, I know, you wanted, right.
When you have two patients.
No, you have bilateral.
Yes, two.
Two. Okay, so, so, yeah. So what can you do? So you get on scene, you deal with the bleeding, which may be minimal, and you see, okay, they were stabbed, okay, we got a problem, we got lung sounds, we got no lung sounds, okay, pneumothorax, right? So what is the EMT supposed to do? You're supposed to apply an occlusive dressing. Why would that make sense? What's the occlusive dressing gonna do? Seal the hole. Stop that air from rushing in. Okay? So you apply an occlusive dressing. In the hospital or the medics, we're gonna do something different. We're gonna put a long needle into the chest to let the air out. Or we're gonna do a thoracostomy, which is like to cut a hole here and put in a tube to allow the fluid, the blood, the air, everything to come out. Okay? These are the options. These are long-term, definitive care. You're not gonna do that. You're just gonna cover it with an occlusive dressing. The only thing is, with this occlusive dressing, you wanna tape it on 3 sides.
Why?
Okay? The bottom corner is left not taped down. The reason is because if you close it up, then you leave in whatever air is in the pleura, and they're gonna have a hard time ever breathing with that lung. That lung's not gonna inflate. So you have to allow, basically, you need 90% or 75% occlusion to stop any more air getting in, but you need some time to allow that lung to reinflate and get the pressure coming in from the trachea and let that,
So with enough pressure, some would exit.
yeah,
None would go.
yes, it will exit, okay?
Why-
And that's
Why
why,
wouldn't more come in?
no, it won't, You're gonna tape it down on 3 sides, no more is gonna really come in, okay?
Well, just like from a regular
No,
little
the
wound.
pressure
It
from the
won't.
inside is gonna hold the.
The pressure on the
That's
inside will be
negative
greater
pressure.
than it'll
But
stop
if there's too
sucking.
much pressure on the inside, it'll put
Okay.
the flap up a drop, and that's enough.
So that's how you deal with it, okay? Here's trying to show taping, again, piece of plastic, works just fine. The medics, if you have a friend who's a medic, we carry something called a Venous guard that we put over an IV or over a needle stick.
Yeah.
So those work, those are plastic, those are occlusive, okay, so those can be used. Alright, we don't go much into gunshot, did you see the graphic? You like that?
that's cool.
Yeah, it was cool, right? Here you go.
The book has a few different terminologies. Do we have to know this for the test? An Asherman seal, a halo chest seal, do we have to know those?
Okay,
Is it in the blue book?
if it's not in the Chumash. Okay,
Stone edition.
gunshot wounds, no, this is Eli's edition.
This is
Oh, that gun is
He's been around for a
scary.
while.
Now it's not very close to the Book of Eli.
Right.
It's really fun.
Gunshot wounds, I really don't go into this much in
Why not?
EMT school. here's your evisceration. You want to shut the light so you can really get a, leave on a good note.
Everyone ready? No AMS? Here we go.
What's the evisceration?
Here you go.
That.
So here's an evisceration.
Where's the person?
Well, this is the chest. This is the abdomen.
That's what's
Well, they're,
inside.
the left side, that's the intestine.
Yeah, that's an evisceration.
Is that the spleen on the bottom there?
It looks like sausages.
The spleen is right there.
That is what evisceration is.
What's the top?
The main thing
The
is,
left side is the LFQ, is the, right?
It's like
top
it's on the left
What's the
side, but
top
the
thing
main
that's
thing is
little
you
darker?
see the
The
intestines, okay? Alright, you can put the light back on if you want. Right, so what's the key here to an evisceration? Do not replace the organs. People go to school for nearly 20 years to learn where that's supposed to go. Okay, you're going to school for a few months. Do not shove it back in, okay?
It's better off outside here.
It's better outside.
But why is that? Does he get
Because you don't know where it's supposed to go.
Let's go back where it came from.
Yeah, where's that?
Well, unless you're twisting it and something.
I can't believe you're arguing with me. I really.
No,
Listen,
that's a good mark.
don't put it back in.
No, that's a good mark. It's like a tangled slinky.
It doesn't just go back together.
Okay, this needs surgical, approach. Don't put it back in.
What do you do with it?
Let me speak. Okay, so what do? The first thing is to understand that the intestines live in a moist environment. Okay, so we're going to use a moist environment. We're going to cover it. We're going to show you on skill nights abdominal pads, great big dressings, special to be used on the abdomen. Okay? Okay, if you like, yes, ABD is the abbreviation for abdomen. So we're going to use that, we're going to soak it in sterile water, it's something that you'll carry on your ambulances. So you're going to moisten a big abdominal pad, place it on, and tape it down. Then you're going to cover the whole thing with an occlusive dressing. Here's the third use of an occlusive dressing. So number one was a neck wound, 4 sides. Number 2 was a sucking chest wound, 3 sides. And number 3 is your evisceration, again, 4 sides. This is going to keep infection out. This is going to keep it moist. Let the surgeon figure out where to put that back, okay? Not your job.
How many sides is the chest? 3?
4.
No, what?
Second chest one is 3 sides.
3. Only the sucking chest wound is 3, everything else is 4.
Put it in ice?
Ari, AVD or
Amputation. So New York State has very specific rules about amputated parts.
No.
Okay?
What do you do with the piece? What do you do with the actual pieces?
Ice, milk.
Do you let it hang and
You gotta let it-
Chocolate.
Throw it out.
New York State has specific rules what to do with amputated parts. Listen carefully, take notes if you need to, but make sure you get this. Assume you have 2 Ziploc bags. Just assume. Where you're getting them from, I don't know. But let's assume. The first Ziploc bag, you are putting ice in the bottom of the Ziploc bag. Okay? Just ice. Nothing else. In the second Ziploc bag, you are putting the amputated part. I'm assuming we're dealing with a finger or a small amputation. If we're dealing with an entire leg, you're gonna have to rethink this with garbage bags.
Challah bag.
Right?
bags.
There we go.
Challah bag will not work for a leg. No.
I don't think they make the challahs by you.
Not leg size. Okay?
Depends on the leg.
Let's buy the chas.
Like a simcha challah.
Yeah. Alright. So, again, let's assume we're dealing with a small amputated part and 2 Ziploc bags. The first bag we are putting what?
Ice.
Ice. As much ice as you want, I don't know, I don't care. The second bag, we are putting the amputated part. This can be wrapped in a sterile dressing, not the big deal here. The big deal here is that the amputated part never touches the ice. Do you understand? The second bag is put into the first bag. Do you all understand this? This is something you must know. For real life, for testing, for everything. That's how it goes. I should say that here. Okay?
Why is that? Why can't the actual
Says store on ice.
touch the?
No, because it will kill
You
skin,
can frostbite.
tissue, nerves, all sorts of damage. We don't want that. Okay? This is how you do it. So you need 2 bags. One gets the ice, one gets the part bag. In the bag goes into the ice bag. That's it. Transport.
Bellevue get like.
Right, why do I mention Bellevue here? No, they don't, they didn't pay me for their,
You can, why can't you put the
Strong, they're
ice
strong
bag into the
inside.
park bag? Does it make, theoretically make a difference?
Yeah.
Why?
because the part can't touch the ice.
Was it the ice into the?
Park can't touch the ice.
No, we're saying if the
Not
ice is in the
touching the
bag
ice,
anyway,
it's
so
the
then
bag.
you can put the.
This is the way it's done. Why do I mention Bellevue? Bellevue is the only replantation hospital in New York City, okay? They have tailors available 24/7. That's what they do. They replant organs, amputations. They're ready for that. It's the only hospital that can do it at any time, day or night. Call in a whole team. That's where you go. It's just that simple. Yeah.
Just because my neighbor confused me. The ice, the little piece of pinky in the bag, that bag goes in the ice bag, right?
Yes.
It could, if there's a bag in, okay, that's it.
Fantastic.
What happens if it touches the thing?
We're expecting a video.
Are you going into
Next
what
session.
happens
This
if
is
it
the hard
touches
part,
ice?
What?
What happens if it touches it? Like,
Yeah,
what's the
exactly.
real reason behind
I want you to
it?
demonstrate.
Because
It's
it
going
can
to
be-
cause damage to
Can I
the... Okay, abdominal injuries we've spoken
We'll give you a
about.
bigger bag.
Don't overdo the bag size.
Pelvic injuries, I don't usually go into this in the EMT school. Trauma centers, this is good to know, it's just general knowledge. Nothing that you can really do with it right now. In Brooklyn, we have 3. Queens,
Isn't Brook-
Staten Island, Bronx, Manhattan. I don't know what you are here. Where are you? You're in Queens?
Yeah.
So Elmhurst, Jamaica, Long Island Jewish, and
We go to Jamaica.
Booth Memorial.
Yeah.
Yeah, you familiar with these hospitals?
Yeah.
That's all it is to.
That's all it goes
They
to
go
South
They go to South
Nassau.
Nassau.
97.
Now if it's a big,
South
if it's a
Trauma.
big trauma.
Brook, do you ever take?
Okay, that's it for tonight.